She was on mute the whole time.
Oh, I was on mute the whole time. I was muted. Oh my goodness. Nobody could hear me.
So,
No wonder people.
we're leaving.
Yes.
She's good now.
Now I'm good. Okay. Hello everyone. Merci, bonsoir, bonsoir à tous. Moi t'aimerais que dit bienvenue à tout le monde qui prend temps yo pour capable venir sur plateforme ça avec yo capable venir dans la plateforme ça. Alors nous avons trois plateformes que nous sur actuellement. YouTube. Alors, YouTube, toujours, parfois, m'habitue avec YouTube. C'est pas la première fois que je fais live YouTube. Connected de Facebook, je n'ai pas de problème avec Facebook, je peux faire live sur Facebook. Mais TikTok, this is the first time. Première fois que je fais TikTok, je vais essayer de regarder comment lier. Alors, pour quelle raison, nous souhaitons nous de moi. Moun qui pas là auparavant, je m'excuse. Ouais, me dit son essai m'a fait parce que m'a parlé, nous pas attendre moi, pas vrai. Pour quelle raison? I was muted the whole time. Nous pas attendre moi. Et pas faire moi ça. So, si vous attendez moi, gagne en chat, private chat, moi sur Restream, c'est plateforme ça m'a utilisé, mais aussi distribué, il diffusé sur YouTube, il diffusé sur Facebook, il diffusé aussi sur TikTok. So, si c'est pour la première fois pour monter sur plateforme ça, mettez non, ok, c'est hello, et puis partagez alors que m'attend plus monde. Merci, moi le numéro est à monter, partagez pour me capable dire qui mon noué, pas vraiment il y a temps pour me voir par plusieurs monde même pas et les moi je pas voir lui. Let me see if I could do it now because let's see. Moi je vais mon petit temps pour capable voir lui sur le chat là alors que au même là pour la première fois partager à nos amis faire connaître que also live, Mrs. Leon, Professor Leon, and if you can join us, please do so. Please do so. Et souhaiter, c'est pour la première fois vous venez. Alors moi-même, c'est pour la première fois, moi, ouvrir chaîne là. Moi, je vais plus de détails. Et je souhaite c'est pas pour la dernière fois. Alors, un moment, je vais essayer de partager quand. Hold on a second, please. See, let me send the link to my friends. Let's see, so they could join now. Okay, all right. Pas connaître sous-tendem, mettez en allo. I just wanna make sure you guys can see me and hear me and introduire tout pour capable voir qui monte ça. Okay. Moi, j'ai quelques personnes qui montent. Cependant, je vais un dialogue avec nous. Comprendre, c'est pour la première fois, c'est un essai à regarder pour moi comment Restream travaille, plateforme ça, parce que voilà, la télé, dans quelques, quelques mois qui étaient dans l'année pour capable voir comment plateforme ça marchait. Parce que il y a un peu de monde qui relève, moi, je dis comment faire sur l'autre plateforme. So, je vais essayer pour moi comment la plateforme marche. Moi, déjà, sur le faire Zoom, classe, c'est pour la première fois, je vais faire session sur différentes plateformes, ça, Facebook, puis TikTok, et puis avec YouTube. OK? Zami, m'pa konnen ki moun wè. Semble-t-il c'est 2-3 moun, m'ta remettre plus moun avant que moi di, ça m'a dit ya. Juste, ou gèle pas capable écrire, can you send me a text or mettez-le dans le chat là pour me capable voir qui moun wè. Sinon, m'a obligé de prendre plus moun. Besoin qu'on comment le marché. Si vous voyez un message, moi pour me capable recevoir, sinon m'a capable répondre. Vous comprenez? So, c'est juste un essai. Si vous ne voulez pas mettre non, that's all right. So, maintenant, en attendant d'aller mettre plus de monde pour moi comment chat la marcher. OK? Par contre, est-ce que vous checkez dans TikTok? OK, TikTok là. Facebook là. But it looks like that your chat again, you pas monter dans ça ensemble. Pas vrai? So, because I only see 3 participants. Comment? Pas avec tous ces problèmes là. But at least on a besoin de forme de communication. Vous comprenez ça, là? Can you chat something for me? I just want to make sure it's working. Vous comprenez? Just say hello. Just say hi. Okay? If you don't want to give me your name, moi, j'ai juste besoin de connaître les marchés. Et me connaître plus moralité sur lui, c'est plus que mon a fini. Partagez sur recevoir lien ça. M'attendre plus mon monter pour me capable continuer live ça. À soir, nous sur 3 différentes plateformes. Nous sur Facebook, nous sur TikTok et puis nous sur YouTube. So, on va connaître sur recevoir lien, partager à vos amis. Partager à vos amis et faire connaître que nous là, nous attendons. OK? OK. On va connaître sur là. OK? Juste voyez un message pour moi. OK? Voyez un message. Peut-être vous voyez un message là, je ne suis pas capable de voir. Même bon téléphone. So, capable de voir un message là pour moi. Ou bien pour me connaître est-ce que ces plateformes n'ont pas travail. Ou bien pas connaître comment pour me joindre le message là. Numéro moi c'est 201 889 8103. 201 889 8103. Amis. Ou bien on capable aussi partager à vos amis si vous joignez, recevoir message ça. OK, je vais déjà promettre l'autre amis dans quelques jours. Comme aujourd'hui, que nous allons aller sur différentes plateformes. À soir, c'est un essai que nous avons fait pour nous capable de voir comment ça marche. Alors, laissez-moi vous dire que c'est là toujours, m'attendre plusieurs mondes pour capable commencer pour nous commencer chat là. So m'attendre non. OK. M'attendre non pour nous capable commencer chat là. OK. Est-ce que partager envoyez un message pour moi c'est monter. OK, il n'est pas monté. Message à pas monter. Non, tu as besoin de ouvrir là, le private chat là. I should be able to see it pour avoir une forme de communication. Vous comprenez ça, là? Oh, okay. What about on YouTube? Okay, I see Augusta, Jean. Bonsoir, Sir Christine. Oh, I can see you now. Bonsoir. Augusta, please. Partagez. C'est pour la première fois. OK? Ouais, ça, je ne suis pas capable de voir, mais quand il y a pour monter sur YouTube là, moi, je vois qui monte. Augusta. OK? Augusta. Bonsoir, Augusta. Merci d'être venu. Partagez. OK? Je souhaite autant de moi. Bienvenue. Alors, c'est une nouvelle plateforme, nous commençons parce que puis les élèves nous toujours d'habitude fait live, des classes sur Zoom. Et puis, nous avons nécessité que nous avons besoin d'aller de l'avant parce que il y a plusieurs plateformes de Yoa et il y a des gens qui m'ont dit que ça m'a aller sur la plateforme. M'a parlé de TikTok, m'a parlé de Facebook, m'a parlé de YouTube. Alors voilà pourquoi à soir moi dit bon essayer pour moi si plateforme ça yo travail. So partager, c'est juste un testing. Yes, it's a testing. Augusta, m'a aussi ba ou numéro moi sous besoin relé moi après. Mais semble-t-il vous connaissez qui mon moyen déjà. Yes, parce que moi ouais. Yes, très bien. Oh, il dit très bien. So, il attendait très bien. OK, so bienvenue, merci. Alors, on t'attend plus de monde toujours pour nous capable continuer. Par contre, oh, semble-t-il c'est dans YouTube ou même moi attendez. Mais pour TikTok, je pas gain accès pas ouais. Comment si bien monde pas connecter avec TikTok. Maybe I could put it here. D'aller essayer regarder comment on peut connecter avec TikTok. So, Augusta, m'a ignoré ou non, c'est juste la première soirée que nous montons sur la plateforme. C'est juste un test. Je dis c'est un test pour nous regarder comment nous aller de l'avant. Parce que d'habitude, nous allons dans Zoom. So, je dis à nous dire, OK, ben, nous avons chance d'aller dans différentes plateformes pour nous capables aider l'autre monde dans l'autre plateforme. Nous avons des TikTok fréquentés, bien. Moi qui te demande pour ça mal TikTok alors m'a déjà une chance c'est pour la première fois moi suis dans TikTok so fanatique TikTok yo peut-être pas vraiment combien fanatique parce que c'est pour première fois moi dans TikTok moi voulais dire un beaucoup de chapeau tout le monde qui branché dans plateforme ça non moi c'est Christine professeur Lyon Mrs. Lyon. Et pour quelle raison, moi, sur la plateforme, ça a souhait, c'est pour me capable d'aider les gens qui ont besoin d'aide pour passer un classe dans le nursing. Ou bien, aussi, sont étudiants qui prennent un test pour LPN ou bien, on va préparer pour un examen pour RN. Moi, capable d'aider pour capable orienter ou de façon que avant aller chita pour examen c'est capable rassurer ou avec confiance que va passer au nom de Jésus et puis avec information matérielle que moi parle sujet moi connais dans communauté vraiment ça c'est me permettre de son crise il y a pile besoin dernièrement me parler un professeur il dit waouh il y a pile bagaille yo caché pour mon noir il y a pile aide que yo pas connaît. Et c'est toujours un privilège, là, il y a un monde qui parle le même langage avec vous. Monde ça, il y a pas comprendre que est capable toujours orienter. Alors, bon, moi introduire tête moi c'est encore Christine Jean-Léon, moi c'est infirmière. Moi alors premier degré moi t'ai dans nursing c'est associé depuis 1998. Et puis en bachelier 2001 et puis en maîtrise en 2013. Actuellement, moi l'école aussi m'a poursuivre. Moi aussi depuis avant Covid, moi toujours me mettre en classe sous pied pour capable aider préparer mon examen. Et pour il y a plusieurs élèves qui allaient qui passaient et gain concours qui étudier pour capable passer pour capable aller so moi ouais nécessité pour capable ouvrir par opportunité à l'autre monde c'est ça fait voilà pourquoi moi venir sur plateforme ça pour capable reach out pour capable faire connexion connecter avec l'autre élève so si vous tendez moi sur plateforme ça souvent l'autre amis qui t'a aimé faire partie de information que nous avons là. D'habitude, nous avons une session là qui fait clôturer et nous avons qui va commencer et maintenant à peu près on a fait de dizaines d'élèves pour pouvoir commencer. OK, on dizaine d'élèves pour pouvoir commencer. Nous sommes capables de faire et m'tarrement partager parce que si vous sous ligne m'tarrement partager c'est ça que ouais m'a parlé over and over again besoin de partager so on capable de plus d'informations pour monde qui parle fini d'accord et quand vous moi dit encore c'est un test c'est pour la première fois m'a faire par contre comment ça marcher même vraiment apprécier aux amis que c'est pour la première fois moi sur TikTok comme on t'a dit peut-être même c'est pour la première fois faire connaissance avec moi. On pas jamais entendre parler de moi-même. Peut-être entendre parler de moi-même. Moi c'est haïtienne. Moi m'a parlé créole pas vrai. Moi pour moi dire moi son infirmière, moi aider élèves passer examen en classe. Ou bien on va le chita pour LPN, ou bien on va le chita pour RN, ou bien même tutor you pour capable aider bon, et comment test strategies while you're in school, you're still struggling. Actuellement, je enseigné dans 3 universités. Souhaitez l'entendre moi. Marie-Germain, welcome. Augusta, pas de problème, ok, mais c'est ça. Ok, je enseigné dans 3 écoles. Moi à Nova University, moi à Galen College et aussi à West Coast University. Et aussi, parfois, je fais PRN on the floor, ok, parce que moi, vraiment hands-on, ok. So, moi toujours, je m'excuse, mais moi après moi sur live. I'm so sorry, my friend, I'm on live. I'll call you later. Anyways, so just so you know, moi, but c'est pour capable aider en pile haïtien pour capable aider au passer examen. Let me say this. Matter of fact, dans le programme moi et à thèse moi pour dissertation moi, nous pas qu'à comprendre qui ça lié. Pas connaître si nous pouvons entendre. Thèse moi, dissertation focus moi carrément comment pour capable aider immigrants haïtiens pour capable passer examen en collection the first time les wali and find out why pour quelle raison ils pas passé pour quelle raison le chita dans examen et puis le sorti you know désappointé le comment find out que pas passé c'est tête chargée vous comprenez parfois il y a des gens qui allé plusieurs fois et on connaît plusieurs states. Nous connaissons comme Floride, c'est 3 fois au barou. Si vous pas passé après 3 fois, vous supposez aller faire remediation. Il y a l'autre state aussi, vous avez seulement 3 chances. Et nous connaissons l'autre state pour aller plusieurs fois. So, il y a un pile bagaille que si vous préparez, c'est bon, on ne peut pas dire c'est un lack of preparation, mais si vous préparez ou pas besoin vraiment gagner un pile problème vous êtes capable éviter. Alors moi-même laissez-moi vous dire moi comment I know what it feels like pour pas passer the first time comme l'autre examen pas passer, OK? Parce que moi-même pas passer première fois. Non. Même deuxième fois pas passer. OK? So, moi, j'ai un témoignage qui est vibrant, certain, et c'est voilà pourquoi moi je dis, OK, I think I know, I master the skills of how to pass. Et moi, je me dis, c'est bon Dieu, merci, parce qu'en plus, fois, je me dis, bon Dieu, je ne sais pas pour quelle raison. J'étais super préparée, mais à chaque fois, je pensais, l'homme était allé, première fois, je pensais, j'étais super préparée, et je fais examen, tout ça, je pensais, je connais, moi l'arrivée moi c'est tout à fait différent. Quand on me dit OK, le envoyer report là-bas moi, quand on va envoyer report encore. Mais le envoyer report là-bas moi ouais que tout ça m'a pas fait bien et puis moi dit OK, on va aller a second time just to make sure moi pour me capable hit the target point c'est pour me garder passer. Non, il faut joindre l'autre point faible encore. So, c'est ça même toujours dit élèves, même le pas l'examen, le envoyer un rapport là-bas pas penser que point faible là ou juste étudier pour lui et puis là aller encore ou juste focaliser sur point faible là et puis guess what yo songer examen yo connaît que tu es allé déjà yo pas jamba ou même examen so c'est ça que l'on peut étudier ou pas étudier pour focaliser seulement sur ça ou faible mais on supposé connaître toute bagaille en général parce que test là il vraiment tricky so moi j'ai un pile pour partager avec vous. Moi souhaiter au fil des temps, on va laisser regarder combien de fois par semaine on va gagner live show ça. C'est sûr, on va c'est dimanche soir, on va cadeau exactement dimanche soir et puis on va l'essayer, qui l'autre jour on va l'essayer aussi jeudi soir. OK? So c'est 2 jours ça pour qu'on y ait moins gagné pour capable bailler temps moins à communauté. Mais seul ça demande c'est pour partager sur une question ou capable aussi mettre questions yo pas quand si autant de bien parce que mon micro m'a blessé en parler fois quand on dit jodi c'est juste un test test de base que m'a fait pour m'introduire à nous-mêmes, pour nous dire qui mon moyen et qui objectif moi. So moi déjà dit m'ba nous background côté me sorti background éducation moi, pas vrai? OK? Et puis objectif moi c'est pour me capable aider plusieurs élèves passer examen NCLEX ça qui est si difficile. Moi aussi faire private tutoring, moi aussi faire cours quand moi dit j'ai 10 élèves m'attendent, moi j'ai un lot pour m'a essayer mettre sous pied pour m'apprendre 10 élèves. On peut y faire de 5 pour m'apprendre l'autre 5 au moins pour me capable commencer. So sous bons amis, sous qu'on a un monde qui besoin pour examiner ça, fait le connaître. Et aussi moi j'ai plusieurs matériels, je vais aussi partager avec vous. Il y a dans le livre, c'est un livre que moi fais sortir, ça c'est une revue que moi fais sortir. This one, c'est volume 1, c'est juste blueprint of the NCLEX. So là où aller dans NCLEX, vous connaissez, vous parlez de blueprint là. Qu'est-ce que ça blueprint là est? Blueprint là, c'est quand vous dites pourcentage, par exemple, managed care. Combien de pourcentage vous testé dans NCLEX? Par exemple, 18 à 23%. Safety and infection, ça c'est un lot blueprint. You know blueprint. Health promotion and maintenance, psychosocial, physiological integrity, pharmacological, reduction of risk potential, physiological adaptation. So tout ça, ça fait partie de blueprint que vous testez dans l'examen. So là où aller, là vous testez et puis vous voyez un report bas où vous dit, ok, Tijan, Marie ou bien Jacques, mais ça vous fait dans chaque session yo. Ou bien you above, you côté yo du near pass. Near pass là, ou still pas passé. Or below passing. Ou bien average, ou bien above, that means you did pass. Okay? So, you voyez session ça ou en pile fois étudier, vous dites mais comment vous me pas étudier avec blueprint ça? Pas un livre qui gagne un blueprint là. Vous comprenez ça là? Ou gagne un livre qui ou gagne texte sujet quand pour maternity ou gagne un sujet sur pédiatrie, nursing, ou gagne qui ça psychiatric nursing, dosage calculations, savez qui l'autre encore psych, pas vraiment gagne blueprint là. So, voilà pourquoi que nous t'es poussé pour nous dire non, faut un livre sur blueprint là. Une seule fois moi un seul livre qui sur blueprint là. OK? Une seule organisation, ou compagnie, moi ouais qui fait blueprint là. Bon, pas ouais l'autre encore. So moi dit voilà pourquoi et blueprint là très important pour moi. Non seulement moi-même le m'a fait classe moi détailler chaque sujet, m'a parlé maternity, pediatric, psych. Cependant blueprint là très important pour capable connaître exactement ça lié. So dans le livre ça, ou pas ouais moi détaillé de fil en aiguille blueprint yo. L'homme fil détaillé yo et puis ou après aussi question qui tu sais quand vous par exemple en question l'homme fin détailler chaque détail session yo, OK? Il y a subsection aussi et puis moi détailler avec moi solidaire comment on pas dire ça renforcer ça au fin apprenant avec question et puis à la fin de chaque chapitre moi dois faire de 10 questions. Livre ça aussi dans fin au galway plusieurs questions on va faire de 100 questions NGN NCLEX 100 questions sur critical care et puis on l'a 200 questions most missed questions on NCLEX. On va prendre ça. On dit comment faire most missed questions on NCLEX. Parce que questions élèves d'habitude ils ont toujours manqué. That's what it is. So c'est ça qu'on va aller faire au fil des temps on va faire plusieurs questions ça au avant mais on encourage à acheter le livre là et aussi moi j'ai volume 2 volume 2 à lui-même c'est all the case studies que m'a parlé de NGN New Generation NCLEX. So c'est ça yo le m'ga fait live show m'ga aussi fait avec élèves OK? So, très important que l'on vini sur plateforme là ou tout gain livre là ou tout préparer sur le n'a fait question pour capable côté mieux et parfois m'a dit faire mes livre là m'ta tester pour moi photo combien on kembe combien on retenu et sous comprendre parce que m'ta comprendre le alors aller dans un complexe il y a différentes étapes question premièrement première étape là, c'est que ça. Nous avons dit qu'on son échelle ou à monter, un ladder ou à climb. Avec première étape question, c'est que ça. C'est tester knowledge. Est-ce qu'on comprend? OK? Quand vous dit tester ce qu'on est the lab results. Combien on normal potassium y OK? The serum level of potassium. Nous tous connaissons 3,5 à 4,5 à 5. Pas vrai? Ou bien vital signs, the normal vital signs ranges. So that's knowledge. Et puis, deuxième étape là, c'est tester your understanding. OK? Comment est-ce qu'on comprend la question? So, you're capable de tester quand vous dites un patient qui on fait liver biopsy, par exemple, et puis le patient ça retourné sous qui bord vous supposez placer patient ça. Est-ce que la bord gauche? Est-ce que la bord droite? Est-ce que vous mettez le supine? Est-ce que vous mettez lateral? So that's your understanding. What do you understand about the question? Okay. Troisième niveau, c'est analysis. Pour analyser question. Et l'autre niveau qui dernier niveau, c'est que ça what is it? Application. Comment appliquer question. Quand vous même question ça me pose, si patient ça li aller dans liver biopsy, OK? Pas connaître si comment tu capable dire moi si ou bien un patient qui allait dans liver biopsy, le patient retourner dans sous dans qui bon mettre patient ça, qui bon encourager pour capable reposer, pour capable coucher. Est-ce que c'est sous bord gauche? Est-ce que c'est sous bord droite? OK? Pas pour aller dans la question avant. C'est juste ça, tu parler, tu causerie n'a fait pour première. Nous pas faire question. Nous pas pouvoir faire question. Nous capable mettre réponse là pour nous capable voir dans YouTube. Le bon patient qui allait dans liver biopsy, le patient retourné. Post-op, liver biopsy. What would be the best position for your patient? Anybody? Marie? Jean? Auguste? Vous capable de répondre? N'importe qui sur live là parce que je ne sais pas tout le monde. Je ne connais pas si bien mon TikTok aussi. That's why I need to make sure to see the TikTok interaction. Je ne sais pas combien de monde qui plugué, qui branché sur TikTok là. So, je ne suis pas quand même capable de voir comment même pour moi interagir avec eux. OK? Est-ce que vous êtes capable de mettre une réponse pour moi? Sur un patient qui allait dans liver biopsy, pas vrai, patient retourne sur floor, sous qui bon encourager patient pour lui reposer. Merci. Gertie Sylvestre, welcome. Par contre, si tu as des questions, and we're looking for some answers. C'est juste sur le premier jour, moi monter, moi brancher sur TikTok, sur live YouTube. Dès qu'on fait ça auparavant, ça fait presque 2 ans. So voilà pourquoi moi retourner ma pour relancer et aussi je pas vraiment 100% à l'aise. So c'est ça que m'a fait chose à aujourd'hui pour me capable voir comment nous peut aller from here on. Merci beaucoup, merci pour tout cœur. Oh, somebody is appreciating. And I love you guys so much. Angie, Augustin, merci Angie. Quand nous pouvons répondre à une question, question 1, nous dit nous avons un patient qui fait aller dans liver biopsy. Le patient retourne sur le floor là. You are the med-surg nurse. Ce qui va ou pour encourager patient ça pour lui reposer et pour quelle raison? Est-ce que c'est sous bras droite? Est-ce que c'est sous bord gauche? Ou bien est-ce que c'est sous supine, sous dos? M'dare mes réponses là. Mettez réponse là pour moi. M'pa ko ka réponse là. Quand vous moi dit m'pa ko à l'aise avec plateforme yo, but soumettez sur YouTube, capable ouais. Je m'excuse. Et m'pa connaît soumettez sur Restream private chat là, m'pa connaît si m'pa capable ouais combien monde qui branché, mais m'pa capable ouais réponse là. Moi besoin réponse. Allô? Moi pas ouais réponse là non, m'pa connaît si nous mettez ou bien m'pa ouais. M'pa connaît réponse là. Okay, you said to the right. Put the pressure on the right side to prevent bleeding. Thank you, Gertie. You are right. So, ça, c'est en forme de understanding. Pour quelle raison? Rationnel là, c'est parce que nous parlons patient bleed. Why? Because the liver is very vascular. That patient can bleed even to death. So voilà pourquoi il faut mettre pression on that right side. So nous te parlé, nous dit qu'il y a 4 différentes étapes. Le aller dans un complexe, il y a 4 différentes étapes questions yo posées, questions qui tester just your knowledge, comme pour lab results, vital signs, you know, dosage calculations like basic. Like, vous comprenez ça, là, pour 1 et 1 font 2. Vous comprenez ça, nous comme ça. That's knowledge, basic questions. Okay? Quand pour qui ça, pour un patient, let's say un patient, patient risk for fall ou ballon call light. Pour qu'il soit ballon call light, c'est parce que ou pas les patients tomber. That's basic knowledge. And that's also basic understanding. By patient call light, remind the patient to call you before you leave the room because you don't want the patient to fall. But encore, nous disons si patient aller dans biopsy, leur sorti post-op biopsy ou supposé mettre patient on the right side parce que you don't want the patient to bleed. That's one. Now, l'autre niveau question nous dit after knowledge, after understanding, then we have analysis where you have to analyze the question. Okay? And then the last one we said is what? Application. So, même si d'abord, même scénario ça, m'dadou patient ça kounye a, mes patients kounye a qui sorti dans liver biopsy et puis kounye a li vin sou floor là. OK? So, patient kounye a qui signe ou symptôme ou ouais que patient ça li gagne complication. OK? Qui sont à tester pour voir qui patient ça gagne complication. Premièrement, patient li has nauseous and vomiting. Patient li nausea. Okay? Deuxièmement, patient complain pain on the right side. Troisièmement, patient do li gagne abdominal discomfort. Et quatrièmement, patient vital signs li montre que patient heart rate li 115, right? Blood pressure patient li 90/50 et puis patient la respirer 28, OK? Respiration patient 28, OK? So, qui ça qui montre que patient kounye a gagne un problème, une complication dans tout ça m'dou là. Petit A nous dit patient gagne pain at the right side. B, patient gagne qui ça? He's complaining of nausea and vomiting. Okay? C, patient's complaining of what? Discomfort on the abdomen. And the last one is the vital signs that shows, what is it? Patient has 90, blood pressure 90/50, heart rate 115, and breathing 28. Okay? M'attend réponse là. Oh, you put the answer. Yes, Gertie, I saw the answer for the understanding question. Now, pour nous chercher analyser question qui plus difficile, c'est niveau de capable dire ça qui plus difficile, OK? Pour que nous chercher faire more critical thinking. So même patient ça qui sorti liver biopsy, il retourne sur floor après qui signe ou un patient gagne une complication. Est-ce que c'est douleur là il gagne en ventre? Est-ce que le patient, si le patient has vomiting, nausea and vomiting? Est-ce que c'est si le patient nous dit the vital signs? Patient has vital signs, what is it, 90/50, pulse 110, and then breathing is 28. Est-ce que vous pouvez pas répondre pour moi si vous n'en comprenez? Parce que je ne pas commettre rien pour capable analyser. Je connais juste ma dire. C'est montrer, je dis à quand moi c'est le premier jour que m'a testé une plateforme pour moi comment elle marche. Le m'pral poser question ça yo, éventuellement ou pral ouais yo ensemble avec. Ou pral capable ouais yo, pral capable décider, ou pral capable aussi choisir. C'est pas juste mal dire. Je dis c'est juste en causerie courte m'a fait ensemble avant. What is the answer, guys? Girfy, what is the answer? Songez, si vous besoin de contacter moi, numéro moi c'est 201 889 8103. 201 889 8103. So what is the answer? Girfy, you got the answer? Vital signs, yes, that's the answer. So vital signs là, nous dit que blood pressure à 90/50. Il pas nécessairement get on temperature. I didn't say the temperature. What else? Patient is having shortness of breath. Breathing is 28. And the pulse is 110. So the heart is trying to compensate. Patient l'a essayé à compensate. Why? Because patient is doing what, guys? I need to hear the keyword. Vital signs. That's the answer. What is the rationale? Bon, oui, rationnel là. C'est ça, rationnel là, aussi important que réponse là. Maintenant, rationnel là. Yes, the answer. Nous dit c'est vital signs. Pour quelle raison? Depuis où monde allait lui faire problème, ok? Depuis où allait faire examen ou bien manipulation ou bien, de quoi dire ça? This one for biopsy, c'est juste un test, pas vrai? Si procédure ça, li gagne un problème, qui problème patient? Li fait l'envant. So of course, you expect the patient to have nausea and vomiting. You expect the patient to have discomfort, not like 10 out of 10, but just minor discomfort in the abdomen. That is expected, okay? And also, what is it? Discomfort, abdominal pain, because it's happening in the GI. But lower vital sign is dropping 90/50. That means what? Patient is what, guys? Patient is losing fluid. That's a sign of what? Bleeding, okay? Hemorrhaging, okay? And Dosonje nous dit the liver is very vascular. So that's why we place the patient on the right side after the biopsy to put pressure, to prevent bleeding. Et si nous have vital signs là are declining, where the blood pressure is dropping, the heart rate is compensating, is going up, the breathing is like going up, that is a sign of hemorrhaging. So that is a key on diagnostic. What would be now? So non seulement de ces quatre types, pas vrai? You pose non qui ça understand knowledge, understanding, analysis, application. So you take our puzzle now. What would you be your prioritization now for this type of patient? Number one, would you push fluid? Number two, would you encourage, would you ask the patient it's okay? Okay? Would you tell the patient, oh, what you're feeling is normal? Number four, would you call the charge nurse for this patient? What is the answer, guys? I have to repeat. Now, nous allons passer dans l'application. Nous dit knowledge, première étape, deuxième étape, understanding, troisième étape, analysis, puis nous allons parler de vital signs. Now, how would you apply? How would you apply? What would you do? How would you intervene? Ça, c'est l'application. So, d'habitude, on pose la question, what would you do first? What would be the first action as a nurse you would do for this patient who's having vital signs, blood pressure is dropping 90/50, heart rate is racing 115, et puis que comme un patient pour la respirer, comment on dit ça, is breathing, having shortness of breath. Okay, so what is your priority? What is the answer? Yeah, mwen réponse là, nous said bleeding. That was the last question. So what would be your priority nursing intervention now for this patient who's bleeding or who's having hemorrhaging? What is your number one? M'di konya nous dépendez différents nous ba quatre options. Premièrement, est-ce qu'on a dit patient it's okay, it's gonna go away, okay, your blood pressure is gonna go back to normal. Number 2, would you call the charge nurse? Number 3, would you call the doctor? Or number 4, would you start fluid? Or would you anticipate the doctor to order fluid? Okay? What's the answer, guys? M konen li difficile parce que nou pa wè opsyon yo, but c'est juste on analyse ma fè avèk nou pou montre nou diferent tip koman question yo build on NCLEX. Ok? Nou pou bon repos la nan, monsye dam. Map gade la nan TikTok, nou wèm gen 3 moun. Yes. M pa konen si moun sa yo si yo kapab tape repos lan. What is the answer? What is the answer? Okay. Est-ce dernier réponse or what is your priority nursing intervention? What is your priority nursing intervention? To a patient who's bleeding. Patient vital signs, we said, is 90/50. Heart rate is, yes, start fluid. There you go. That is the answer, guys. We're not going to call the doctor. That's usually not our priority. Instance, côté que supposé les docteurs là. Leur pas capable faire rien. That's when you call the doctor. You guys know that. Leur pas capable faire rien quand pour un patient qui a critical potassium, critical values. Qu'est-ce que ça va faire? Premièrement, you always want to assess the patient. That's always the first thing you want to do before you call the doctor. Quand pour un patient, you will the monitor tech. They do, oh, patient, your patient is having VTAC. What are you going to do? Don't go crazy. Don't call the doctor. You're going to, what are you going to do? Check your patient. You need to assess the patient. You're not going to call the doctor because the doctor's not like, what do you want me to do? Okay? What do you want me to do for you? Remember, moi toujours dit, as nurses, we are little docs. Pour quelle raison nous relève tête nous? Si docteur, pour quelle raison c'est nous-mêmes qui là avec patient. Nous ouais tout bagaille. Parfois c'est un passé ou nous-mêmes qui sauve la vie d'un patient même avant docteur là parce que nous toujours avec patient. Et même bagaille docteur pral prescrit, nous juste pas de licence pour nous prescrire. Cependant, nous toujours anticiper ça docteur a prescrit. Et c'est ça que fait si docteur a prescrit un bagage qui pas bon, c'est nous même qui parle dit docteur là, regardez docteur, ça pas bon pour patient non. Remember your S bar, the last part of it is your recommendation. The R is your recommendation, right? Premier S là nous c'est situation, B background, A assessment and R is your recommendation. Qui sont recommandés à docteur là? Si on dit c'est moi-même qui peux recommander à docteur là pour prescrire patient au bagage, cela signifie moi supposé connaître qui ça docteur là peut prescrire. You guys never thought about that, right? Nous pas connaître. Est-ce qu'on te connaît ou son petit docteur? Oh yeah, you better give yourself a pep talk. Ou bien battre un petit encouragement. Et c'est ça que fait l'NCLEX à poser aux questions. L'ochita dans NCLEX, en pile nous pas comme ça nous fait, nous get tête bouillée parce que NCLEX, avant pour yon bon licence là, yon besoin safe. Safe in communicating. Safety in charting. Safety in medicating. Safety in communicating to your doctor. Safety in planning ahead. Safety is the basic of everything. Are you safe? Non, so pas recommander docteur. Is it safe? Parce que docteur là, il y a deux fois il bouille, il y a 200 patients pour le take care. He doesn't see the patient. It's just like the nurse practitioners who's working for the doctors, the same thing. You really okay, my patient is bleeding, or my patient is not doing well. You might know, what would you, okay, tell me the signs and symptoms. You should be telling them also the signs and symptoms. So you might know, then what would you like to recommend for your patient? C'est comme ça un clex vle prend. So c'est pas comme c'est local do ça pour faire, but ou même ou déjà anticipate what to order, what to recommend, and what to do first. So c'est ça que fait l'on a regardé toute stratégies yo. Est-ce que tu connais AdPie? C'est une stratégie que yo utilisé pour capable aider patient. M'a parlé AdPie, which means what? A for assessment, D for diagnosis, pas vrai, m'a parlé nursing, pas vrai? And P for planning, pas vrai? Et puis I for implementation or intervention, and then E for evaluation. So that is one of the strategies, but get a lot of strategy. Get Maslow hierarchy. Everybody knows about Maslow hierarchy, pas vrai? ABC, airway first. What do you mean by that? Ou gen deux patients, yon fèk vini nan floor la, et puis gon lot qui gon COPD, but tous les deux having shortness of breath, okay? One just admitted on your floor with shortness of breath, one with COPD, who's also having shortness of breath. Which patient will you see first? They're both having shortness of breath, right? Hello? Mettez réponse là pour moi vite, s'il vous plaît. Mettez réponse là pour moi vite. Je prends une question, ça va être très facile. Again, that's understanding. Pas vrai? Understanding. Très, très, très facile. Mettez réponse là pour moi dans TikTok. Attendez. Batandem. TikTok. Mon TikTok, moi, je ne pas avec même. Batandez. Ou bien, c'est moi-même. Quand on me dit, c'est la première fois dans TikTok, je ne sais pas comment le système TikTok là travaille bien. Vous comprenez? Patient avec moi et puis capable partager avec l'autre amis pour capable dire next time, every week it's gonna get better. Every week it's gonna get better. Okay? So what is the answer, guys? Ou gen deux patients qui is having shortness of breath. Oh, Gertie, ou pas mettre réponse là, non? Marie, ou pas mettre réponse là? Angie, ou pas mettre réponse là? Auguste, ou pas qu'on mette réponse là? Nous allons pas avec moi encore, nous allons aller. Nous allons aller, nous pas avec moi. OK. Attendez réponse là. So, il y a deux monde qui ont shortness of breath. One with COPD. OK. He's having shortness of breath. But then you have a new admission who's having shortness of breath. Which patient would you see first? Which patient would you see first, guys? Which one would you assist first? Oh, well, you already actually assessed them, but which one would you assist? Depuis, il n'y a pas assist at intervention. Nous sommes parlé de AdPie. AdPie, si nous avons breakdown AdPie, le assessment, il y a deux types d'assessment. We're talking about subjective and objective. Subjective is what your patient says. And objective data is what you observe, what you feel, what you see. It's all your senses, including what others have told you. Diagnosis, there's two types of diagnosis. Risk and actual. Planning, there are two types of planning. Short-term and long-term. And interventions, there's gazillion interventions. It will evaluate still. So what's the answer, guys? Could you charge it for me? Actually, okay, charge. You could just turn on the light and then do it that. Let's see. Yeah. So, guys, notez. Perdu, no? Okay. So the answer, the new admission. Perfect. That was easy. It's the new admission. Okay. So, bon, moi encore, moi qui fais vidéo, moi dis non, moi c'est Christine. I've been a nurse since 1998 avec associé, j'ai gradué et puis moi prends bachelier encore dans nursing, moi prends maîtrise moi dans nursing en 2013 et actuellement moi j'ai my doctorate. I'm also doing in nursing research. Et qui ça Moi, dit thèse ou dissertation, moi, c'est my people, Haitian people. OK? Que moi, voulais connaître pour quelles raisons ils sont pas capables de passer un flex the first time, les aller chita, à prendre test là. Moi, sûr que vous connaissez raison déjà. But moi, besoin qu'on en détail pour other reasons. Et comment qui un programme vous êtes capable de faire pour capable aider avec cause là. Vous comprenez? So that's the goal. So nous dit que nous allons essayer de rencontrer 2 fois par semaine. On peut aller parler avec ma connaître monde qui parle anglais seulement ou bien monde qui parle aussi parler créole un jour. Mais dimanche, c'est 2 jours ça on d'aller me rencontrer dimanche 8h du soir avec jeudi 8h du soir. So des 2 jours ça on va essayer côté nous débattre faire case studies, live case studies, poser questions, côté au capable de questions et vous répondre NGN style. Parce que moi j'ai 2 livres que moi faire sortir. Premier livre là, c'est lui-même n'a regardé là, volume 1, c'est The Blueprint. Blueprint, Laura Chita, allez prendre examen et puis on dit OK, Jeanne, ou pas passer en physiological adaptation là. Ou pas passer managed care, mais combien ou get ou pass for safety and infection. So that's the blueprint. It breaks it down in details, okay? Et m't'arrêter sous acheter livre ça, très important pour capable lire tout détail yo. Tant pis pas aller dans question yo, dans fin livre là et pour quand ça fini et pas comme ça pour faire. Parce que faut qu'on comprendre le concept yo et c'est ça que en pile là nous pas passer un classe, nous pas comprendre blueprint là. Blueprint là c'est un guide, c'est un margin pour capable aider. Vous comprenez? Quand vous parlez de ethical, quand vous simplement do ask what is the difference between advanced directives and living will? Et qui ça côté ça catégoriser dans blueprint là? Est-ce que vous connaissez? Est-ce qu'on juste besoin d'une question seulement ou bien ou besoin qu'on ça signifie? What is the difference between advanced directives and a living will? M'attends réponse là oui? M'attends réponse là. Advanced directives and a living will. OK? Pardon avec une question pour moi. So nous dit c'est ça livre là, il est composé de tout blueprint inclus nous gagnons 100 questions NGN et puis 200 another 100 questions on critical thinking skills or critical care et puis 200 questions sur next what is it most questions people miss on NCLEX. Et je vais poser une avant de finir parce que live là pas kembel 1 heure temps live là that's it. OK? Nous pas kembel le secteur. So ou bien réponse là pour moi, m'attendre réponse là non, m'attendre réponse là. The difference between advanced directives and a living will. Nous va continuer. So c'est assez premier volume là. Et puis deuxième volume là c'est case studies of all NGN case studies. Nous allons parler de différents types case studies yo. Différents types styles NGN. Le plus de NGN, il y a tout le monde qui vient la tremblade parce que NGN, wow. L'on aller dans l'examen, il y a des gens qui allent dans l'examen, ils disent wow, nous t'es jeune, plus fort question, c'est NGN. Non, c'est juste 18 questions et c'est seulement 3 case studies. Chaque case studies, il y a à peu près 6 questions. Donc 3 fois 6, 18. Nous comprenons? So, il paraît parcours, c'est un pile question, il pose ici, il y a crédit partiel, mais ça va veut dire aussi question c'est 5 et puis ou même ou bien 3 ou qu'à penser que vous allez avoir 1. No, maybe you get partial point, but you at least you need to have 4 out of 5 to get 1 point. Vous comprenez ça me là? So yo dit li aider à cause de NGN puis faut monde pour y a passé examen because of the partial credit. Mais cependant, it's still challenging. So deuxième volume livre nous écrit c'est case studies et tout type yo. M'a parlé de un drop down, si m'ta dit comment pour faire un Foley catheter from A to Z. Si est-ce qu'on connaît comment pour teach un patient comment pour utiliser the metered dose inhaler, the MDI. Comment on peut faire un IM injection A to Z? Comment on peut insert IV for your patient peripheral A to Z? That's what you call what you call the order questions, and then also drag and drop. There's also the matrix style. What else? Gain aussi the bow tie style. Okay, côté disease là dans mi-temps, et puis gain deux réponses, action priority assessment, l'autre boa a priority action tout dans chaque, et puis dans mi-temps c'est maladie pour bay non maladie, et on a bon quatre différentes maladies. So gain différents types, so gain à peu près 10 différents types ça on va faire case studies avec. Okay, so get ready, it's gonna be interesting and it's gonna be real. Cependant il est bon pendant ma fait question yo pour capable gen livre là dans main. Moi carrément gen livre là dans main, et bon moi dit ça que pour nous même capter sur live là, c'est 2 for 1. Le m'a comparé, faut me dire ça parce que me faire comparaison livre là avec Sanders, avec tout l'autre programme yo gen de yo a. Li moi été yo dit prix li vraiment abordable. Okay, but I even malgré yo mon suggested price and I still drop it that lower. Et puis yo dit moi que livre ça li a aidé en tous les élèves passer examen yo selon recherche qui fait et contenu qui est dans livre ça. Okay, so that's the basic understanding for this book, de livre. Mwen bon troisième aussi kap sorti, but that's for dosage calculations. Je vais pas parler de ça, mais carrément juste focus sur de ça. Sous besoin gen livre là, ou capable brûler moi au 201 889 8103. 201 889 8103. Suggestion c'était pour me vendre livre là dans range what is it, $80, but I drop it down $49.99. So quelqu'un coût avec moi, okay, for each. So basically $99 or $100 for both. Okay, so basically it's 2 for 1. Si vous avez payé presque bouillon, now it's 2 for 1. Okay, so just so you know, get l'autre bagage va le suggérer ba ou, but définitivement, moi pas qu'à quitter sans without the case studies and without the blueprint. Qui c'est on guide pour capable aider au passer examen. Aussi, my Gertie, living will is what the patient would like to be done in case they no longer can make decision. Okay, that's living will. What about advanced directives? Now, great job, Gertie. Great job. Okay. Bon l'autre monde qui tape pas correct. Bon l'autre monde. Est-ce que bon l'autre monde qui va taper? What is advanced directives? She just answered living will. Est-ce que bon monde qui capable taper? Et nous ça, so moi juste aller dans le livre là, dans page 2, moi j'ai ta réponse là. So elle me pose nous mes réponses là. Je vais lire pour nous. Advanced directives. Yeah, deux types. There are 2 advanced directives. No point in doing this highway. Living will and durable power of attorney for healthcare. That's what we call health proxy. So living will qui s'allie, c'est le monde pas capable de décider pour compte lui mettre qui ça. Non, le monde avant de mourir, il dit mais ça l'état mais pour faire pour lui. OK, ou bien s'il pas capable manger encore pas bali et du tout, ou bien s'il pas capable ressusciter ici et DNA. There's also DNI, do not intubate. There's also DNH, il va pas hospitaliser, do not hospitalize. That's living will. Avant que le pas capable parler, le pas capable prendre décision ou bien moralement, mentalement le pas là ou bien le pas capable parler, il écrit bagay ça yo. Cependant, double power of attorney, c'est un monde qui délégué pour prendre décision ça, yo faire décision yo pour lui. Et c'est ça que parfois, yo toujours gen côté yo dit est-ce que mon est capable de changer l'idée? Mon est délégué pour faire décision pour lui. Est-ce que mon est capable de changer l'idée? Est-ce que depuis loi fin écrit parce que c'est un avocat sien, docteur sien, est-ce que c'est set in stone? Est-ce que vous capable de changer lui? Okay, he said this document designate a person, that's the doable of attorney. This document designate a person often refers to as healthcare agent or surrogate to make healthcare decisions on behalf when the patient is no longer able to do so. Okay? So, si je pose une question pour Nia, here's a question pour moi finir mes questions. A nurse is caring for a client who is unconscious following a severe stroke. The client has a signed living will stating they do not want to be placed on a mechanical ventilation. The client daughter insists that everything possible to be done to save her parents' lives. What is the nurse's best action? So, c'est très important, l'on applique en question au besoin qu'on qui point qui très important. Qu'est-ce qui est important dans la question ça pour nous connaître, pour nous songer dans tête parce que il y a des bagages yo mettent dans la question they are distractors, OK? Ou pas besoin ça. Et d'habitude, before mon yo fort yo capable narrow it down to two, but ou pas connaître dans deux ça yo which one is it. So, ou besoin premièrement, what's going on? What's the problem? Et qui sa question mando? En pile fois question mando on bagay ou même moi chercher on là, ou ba on l'autre réponse. Et pas bon, m'appli pour encore. A nurse is caring for a client who's unconscious following a severe stroke. The client has a signed living will stating that they don't want to be placed on a mechanical ventilation. The daughter insists that everything possible to be done to save her parents' lives. What is the nurse's best action? Number one, honor the daughter wishes and notify the provider to intubate the client. Nous souhaitons attendre les réponses parce que nous allons faire les réponses. B. Explain the daughter that the provider must follow her request as the next of kin. C. Inform the daughter that the client has an advance directives and advocate for those documented wishes. And D. Ask the provider to delay decision making until the family reaches an agreement. What is the answer, guys? Nous devons aller en réponse encore, option yo. A. Honor the daughter wishes and notify the provider to intubate the client. B. Explain to the daughter that the provider must follow her request as next of kin. C. Inform the daughter that the client has an advance directives and advocate for those documented wishes. And the last one, D as in David, ask the provider to delay decision making until the family reaches an agreement. What is the answer, guys? What is the answer? Nous allons aller. Nous finir, nous allons quitter live là. That will be it for tonight. But nous avons besoin de faire dernière question ça avec nous. Et puis, nous allons mettre le téléphone sous le chat là pour nous capables de les moins si nous avons besoin. 201 889 81 03. Si nous avons besoin, on appelle. This is my phone number. Here for some, guys. M'attendez. Songez, nous sommes parlé de living will and durable of attorney. Qui en bas catégorie Advanced directives. So, les appels advanced directives, c'est deux bagages ça vous besoin de connaître. Okay? All right. Here's my phone number. Okay, patient wishes. Gertie said it's patient wishes. Let me see. Is it C, D? Gertie, be more specific. Is it A, B, C, D? A, again, honor the daughter wishes and notify the provider to intubate the client. Is that what you said, Gertie? B, explain to the daughter that the provider must follow her request as the next of kin. C, inform the daughter that the client has an advance directives and advocate for those documented wishes. And D, ask the provider to delay decision making until the family reaches an agreement. Okay, songez question c'est the nurse is caring for the client who is unconscious following severe stroke. The client has signed live-in will stating they don't want to be placed on mechanical ventilation. The client's daughter insists that everything possible to be done to save her parents' lives. What is the nurse's best action? Depuis on parle d'action, c'est pas assessment qu'elle fait, c'est intervention. Toujours songez ça. Et puis, pour quelle raison, ouais, daughter a changé l'idée, pour quelle raison, why? Because this is not the live-in will her mom signed. She is the durable of what? Of attorney. Does it make sense? She's the POA, guys, power of attorney. C'est ça qu'elle est capable de faire des faits. But si c'est maman qui te dit non, pas bon moins mechanical ventilation, il va pas changer. Okay? So what's the answer? C. Gertie says C. C says the nurse must advocate for the client documented wishes as outlined in the advance directives, even if they conflict with family requests. So, exactement. Si pas, that means patient ça, il te gon live-in will, so même le petit la vin parler, si ou pas surrogate, si patient avant, li te rive dans condition telle, li pas de ba ou, power of attorney, ou pas capable de faire des faits. C'est ça que fait le cela camper pour le capable, il va pas le défendre. Il va pas le défendre. Qui va la défendre? Patient la défendre. Il va pas le défendre et petite fille. Parce que petite fille n'a pas un power of attorney. C'est exactement ça qui passe là. Parce que si petite là c'est power of attorney, of course we have to go by what she says because that's why patient avant, il arrive dans condition ça il te dit, il arrive dans condition ça petite là pour décider pour moi. Nous comprenons? So parce que patient est écrit living will, so nurse l'a dit. The answer says the nurse must advocate for the patient documented wishes. That's her live-in will. As outlined in the advance directives, even they conflict with family requests. Can you imagine? Ou gon famille où maman a souffri et puis qu'on n'a pas qu'à défendre lui parce que maman a déjà écrit living will. Haïtien là, nous va prendre ça. Haïtien pas écrit living will. Et living will là très important. Vous comprenez? But Haïtien, il n'y a pas un pile là-dedans, pas écrit living will. But Haïtien, pas écrit living will. Les arrivés dans conditions comme ça. So, pensez, est-ce ne soit pas qu'à dire patient, il y a un bagage qui écrit? Non, il n'y a pas jamais pas écrit. So, c'est famille là, qui décider. Parce que ce n'est pas tout le monde qui a living will. So, quand j'ai une question aussi, qui dit, what if the patient doesn't have a living will? So, who make the decision for the client? When the client was incapacitated, patient pas qu'à parler, so c'est parents, famille, petite qui va parler pour patient parce que patient pas gagné written document. Et comment nous les written documents ça yo? Living will. OK? So, pense m'a prêté là à soir. OK? Comme vous m'avez dit, c'est un tel jodi sur 3 différentes plateformes ça yo, YouTube, sur TikTok et puis sur Facebook. Mais pas connaître combien de monde qui suivent moi sur Facebook, pas moi qui sur TikTok, moi checker sur YouTube Et côté moyen, pas connaît ça les connecter toutes trois plateformes ensemble, but that's what it is. But m'pral retourner encore jeudi si Dieu veut à 8 heures du soir. Ma PC est le consistant avec nous jusqu'à ce que nous venions familiariser avec moi parce que nous ne connaissons pas encore. I am Mrs. Leon qui voulait aider moun dans la communauté à passer examen qui difficile qui relève NCLEX. Que ce soit pour aller pour LPNO, que ce soit pour aller pour RNO, moi carrément aido. Moi actuellement à enseigner dans trois différentes écoles, Nova, West Coast, Galen, and I've been teaching since 2007. Moi gagné trois livres, moi écrit. Actuellement, il y a trois qui sont sortis déjà. Une sur Clinical Journal et deux ça volume 1, volume 2 pour aider à passer un clex. Moi, il y a l'autre livre aussi, moi, je conseiller pour capable de passer. Mais cependant, c'est comme ça nous pour nous. My TikTok friends, thank you for joining. And I appreciate you. Pour aujourd'hui, nous fini. So, encore, j'étais bien content avec nous sur live là. Bon, m'écrit numéro au moins. Nous sommes capables de brûler. Moi, si il y a plus de questions, comme moi, dis moi, il y a 5 élèves pour nous commencer online class là. Moi, tu as besoin de 5 autres élèves. So, si vous avez 10 autres amis pour nous être capables de commencer l'autre classe là, capable de venir. OK? Et puis, je vais nous prix tout bagay ça. Laurel et moi. Je vais écrire my number again. Je vais mettre déjà sur YouTube. Je vais l'écrire sur TikTok. My phone number is 201 889-8103. So you guys can call me. OK, moi fini. Est-ce que mon autre question avant pour m'aller? I promise you, I will not keep you no more than 1 hour every time we meet. Because I know you guys are busy. I'm busy. So just so you know, I'm done. All right? Any other questions for me? No? Okay. Eh bien, merci d'être que nous devons participer avec. I love you guys so much. And I hope you tell your friends and share this live. And next time, we will have more fun. Okay? Thank you so much and have a good night. God bless. Bye-bye. This one. Okay, this one. Perfect. Okay, as you can see, okay, there you go. And I'll go. Hello, everyone. I am on. Let's turn this mic on. The mic. What it says maximize. Okay. All right, it's the mic. Okay, I'm waiting for everyone to join me. Hello, everyone. I hope you all can see me and hear me. Welcome, welcome, welcome. We're starting at 8:30, so please share the live. Share the live. Share the live. We're waiting for everyone to join. Okay, share the live. Okay. We're waiting for everybody to join. Everything is on. All right. So we hope the turnout is better, or it's not gonna go until 8:30. Maybe that's what it is. In the meantime, let me share and enjoy the music. Let me share to some more students. Mm. We are starting at 8:30. Mm. What nurses must know on the complementation gestures. Yeah. Okay. Let's see. Um, Eli? Eli? I don't know why it stops. Oh, it's the camera. Oh, I need to show my face. What do you think I need to show my face? I need to show my face. Could you please help me? Disable camera. There you go. Yeah, but okay. All right. I think I can start, but I'm still waiting. It's 10 minutes. But how do I show my face? Welcome, everyone. Those of you who are here, please share the live. And in 10 minutes, we will, actually less than 10 minutes, we will start. Partagez, partagez, partagez. Okay. Comme tout le monde, partagez, partagez. And we will start. Welcome, welcome, bienvenue, bienvenue. Dans 6 minutes, on va commencer. I hope you guys can hear me. If you can hear me, please give me a thumb up on YouTube or wherever you are. Let me see. Live. Let's reload that. Let's reload. You guys can hear me. If you can hear me, please give me a thumb up on YouTube or wherever you are. Let me see. Live. Let's reload that. Okay, I see you too. You can hear me. If you can hear me, please give me a up on YouTube or wherever you are. See. Let's reload that. Okay, guys. All right. Okay, I see you too. You can hear me. If you can hear me. Okay, just wanted to try. The YouTube is working. Perfect. Okay. All right. Okay. So we are waiting for everyone. It's almost time, 6 more minutes. Share the live in the meantime while we're waiting. All right, guys, I'm waiting for you. There's 4 more minutes to go. Let's go, let's go, let's go. Share the live. On a commencé à exactement à 8h30 comme ça a été annoncé. Please share. So share the live, please. All right, guys. Okay. All right. Share the live. Oh, we're checking just to make sure. Okay, so assoya nous avons un sujet palpitant d'intérêt. It's what nurses must know on mechanical ventilation and chest tubes. So, if you get questions, réponses, so n'attend tout le monde. Partagez, partagez. Please, please, partagez. Okay. Let's see. All right. Bon qui vini, no capable mettre non. Okay, put your name and say who you are and welcome, welcome. It's been a week. Jeudi, c'est le deuxième jour que n'a essayé plateforme ça. Côté live on TikTok, Facebook, as well as YouTube. So we are trying all 3 platforms and see how it works out. So thank you for joining us. In 2 minutes, we will start. Ou même qui gagne un problème dans NCLEX, si vous avez un problème pour capable comprendre le concept ça yo, parfois les questions yo vini dans l'examen ou bien on fait review questions and you still don't understand. So as well, we're gonna break everything to light, everything down. Pour capable arriver dans NCLEX, n'importe question yo pose que ce soit chest tubes ou mechanical ventilation ou pas rater yo. Très, très, très important. Welcome, welcome. I see more people are joining. However, for your name and say hi. Say hi, say who you are, say your name. Welcome, welcome, welcome. In 1 minute, we will start. Please share with somebody. And as you know, I wanted to do this like twice a week, but because of my schedule, it's impossible because I go to school full-time and I work full-time. So this is an addition just to help my NCLEX students or those of you who are getting ready for NCLEX, those of you who are even in school, because some of you are in school and other research or critical care, and you are getting ready for graduation. So you also want to be part of the slide. So, vous avez me dit partager à zami, share with your friend so that they too can be part of this knowledge, because we understand nursing is no joke. The concepts are not easy. So that's why we want to offer to our community a free live services. Well, yeah, really free live service just to help you guys in case you have any questions, whether you're taking an exams or whether you are struggling with any concept, chest tubes or mechanical ventilation or any concepts, and we're here to help you. So that's why here we go. So now it's 8:30, so we're about to start, and we would like to start with a word of prayer. So bow your heads and let's all right, let's have a word of prayer. Father God, we thank you for giving us another day, another opportunity, another chance to be alive, and another chance to also be on this platform. This is our second day, deuxième jour sur plateforme ça. We expect greatness, and we ask you to come by here and be on the slide with us, and also bless every student that are joining on the slide, whether they are in nursing school, they're not yet graduated, they have not yet graduated, and those of them who already graduated and they're all waiting for their to go sit for their NCLEX, whether LPN or RN. We ask you to bless them unmeasurably, bless their family, forgive our sins. In Jesus' name we pray, amen. Okay, guys, welcome. I cannot see so many faces and so many people that are joining. Parce que je ne suis pas capable de voir tout. Cependant, je vais partager ou même qui sont live ça, ou je vais partager avec amis ou avec moun. Par contre, si nous aimons bien, si the lighting, yes, this is better lighting. Thank you so much, hubby. Okay. All right, guys. So last week, the first time when we joined, nous te dit c'est première fois que nous tap launch. This is a new thing that we're trying to see we could reach more people to help them to pass their NCLEX. As you all know, my name is Mrs. Leon, Professor Leon. I've been a nurse since 1998, and also I have been teaching since 2007, but I've been a nurse since 1998. And I have all my degrees are really in nursing, my associate in nursing, my bachelor in nursing, my master's degree in nursing, and currently I'm doing my research at Barry University. Again, it's in nursing. And my dissertation focus, guys, believe it or not, it's how to help the immigrants, especially Haitian population, our nurses, how to help them to pass NCLEX the first time, and finding out the barriers, why they're not being successful. Why is it a struggle for them? A lot of people said, well, we know already it's a language problem. No, it's not. It's not just a language. Yes, that could be one of the reasons, definitely. However, c'est pas seule raison ça qui fait yo pas capable passer NCLEX yo. Vous comprenez? So, on va faire recherche pour capable connaître comment, parce que I'm on a journey to help my people, and especially the immigrant population, the Haitian. Et c'est ça que fait, ou même qui connaît, ou gen moun qui peut passer examen yo, ou même qui connaît, gen moun qui connaît ça pour yo faire chercher moun pour aider yo. I know it's no joke, and especially here in Miami, because I've been here for a year. I moved from Tampa to here. Le map gade ma l'hôpital, nursing home, tout partout, guess what? I'm capable de 80% of our healthcare workers, especially nurses, c'est à moi haïtien yo. Moi ap mande ki sa ka passe, it looks like haïtien ap take over this industry for real, maybe the next 10 years or so, or 5 years. Ou comprendre? So, en pile haïtien intéressé dans apprendre comment être une infirmière ou infirmier. Cependant, ou besoin be the best nurse that God wants you to be. Be the best nurses God wants you to be. So voilà pourquoi I recently launched 2 books on NCLEX. The first one is Volume 1, NCLEX Master Review, Volume 1, right? And this is a whole blueprint for NCLEX, okay? So those of you who have already purchased this book, and I have reached to some of you, mais moi, est-ce que nous lisons livre là, m'ta remen pour n'a pas étudier, c'est pas juste aller dans question yo. C'est très 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 important ou supposé lire de A jusqu'à Z, page 1 jusqu'à page the last page here. So it's important that you know everything, every detail, because sometimes you go to your exam, you're like, okay, of course they're giving you questions, but it's like if you don't know the content, you will not be able to be successful. So that's Volume 1. And Volume 2, it's all the 10 types. Did you know there are 10 types NGN? Yes, 10 types NGN case studies. We're talking about, some of you know the bow tie, the matrix, the drag and drop, the fill in the blanks, and some you don't even know. And the second volume, which I don't have here with me, I need to order copies. And by maybe the next 2 weeks or so, I will have the copies. And we break those case studies down. And that's what also, when I'm having the live, I will be sharing those with you. Not all of them, because it takes a long time just to get through one case study. So, c'est ça, m'bral partager avec nous le nous gen case studies. And also, I'll be sharing some health facts. Like, mwen gen pil bagay for COVID-19. I found an update about COVID-19. M'bral partager ça avec nous. Pil lot bagay. Some natural things that you need to take for your health. Parce que en pil fois, yo di, Black people, we're like the last people to know anything. Moi-même, moi là, m'pral aider ou capable connaître tout bagay sa yo. So we have a lot of goodies for you on this live, guys. And thank you so much for joining us tonight. And please share while you are joining in. And I'm telling you tonight, it's going to be a fantastic night. And I'm full of information for you. Just imagine, this week I was at Jackson hospital, the burn unit, the trauma center. Of course, we saw a lot of people on ventilation. And that's what actually compelled me to actually talk on mechanical ventilation and chest tube this week. So that's why I'm going to break it down for you by the time you leave this live. Any questions on mechanical ventilation as well as chest tube, you will know. Et pas gen question nan enklex ou pas supposé konnen après live ça. Ou capable aussi sûr que ou pral tande l'encore, but pas ta vle que question yo pas répondre. And also get ready because I also have questions at the end of each presentation for you. All right, my YouTube, welcome. My TikTok, I don't know where, if they're all plugging in, somebody check for me. Welcome, TikTok. Excuse me. Oh, wow. All right, so we're going to try to see if our TikTok platform is working. As I told you guys, this is new to us. So please bear with us, and I appreciate your patience so far. So thank you so much. And we will give those announcements again at the end of presentation. And we don't want to keep you more than 1 hour, promise. Okay, so the first thing I want to talk about is ventilation. Ventilation. Ventilator base. What is that? M'tareme que si ça fait m'a regarder si m'ka plus son parce que m'tareme pas dans m'a fait question yo pour moun répondre. M'tareme just put your name and say hi, join. If you're on YouTube, we really want you to put your name so that I know, because when I ask questions, you ought to be able to answer the questions. Sinon, avec qui moun bral travail. Okay, so also if you're not able to maybe here, I ought to see that chat here so that I could see whether they are answering, because I don't see the names here. All right, I just want to make sure. But anyways, let's go. All right, ventilator basics. Who requires mechanical ventilation? Si m'ta pose question ça c'est une question très simple, pas vrai? Qui moun qui besoin to be placed on mechanical ventilation? Of course, you would tell me people whose lungs are failing. Okay, poumon yo pa travay encore. Mechanical, or what is it? Motor vehicle accident, MVA. Ki lot moun encore? Moun ki gen flare chest, pas vrai, après on mechanical ventilation. Ou bien si moun nan so tombe, on terrible accident, lungs li collapse, li pa travay encore. By the way, when we're talking about collapsed lungs, there are two terms. There's partial, there's also complete lung collapse. Anybody knows what are these medical terminology? If I were to ask you, let's say someone has a partial lungs collapse, what is the medical terminology? Répondez pour moi sur TikTok là, répondez pour moi. The partial, if someone has a partial lung collapse, what is the medical terminology for that, guys? YouTube là, m'pa kowe yo répond. Chat, please répond so I could move forward, because I know you guys are here. However, we want to make this interactive for you. This is your live. I'm doing it for you. So si on get partial lung collapse versus complete lung collapse, these terminology are different. Okay, I'm going to give you guys the answer since I cannot see the answer here myself. But please, at any time you know the answer, allez na YouTube la and you guys can type it. So if someone has partial lung collapse, that's what you call atelectasis. That's the medical terminology. Did you know that? That's partial lung collapse. Whereas if their lungs are completely collapsed, that's what you call pneumothorax. And pneumothorax, when you think of pneumothorax, since I've compared pneumothorax and hemothorax, these are two different terminologies. So in the word hemothorax, you hear the word blood, heme, blood. So that means the patient has blood inside their lungs, not just the surrounding. We're talking about inside also. And what about pneumothorax? Pneumothorax, that's air in the lungs, okay? Air is in the lungs, so that's pneumothorax. So now you understand. I have some more medical terminology for you before we move forward. So we already understand it's people whose lungs are failing, they have respiratory failure, right? And now negative pressure ventilation. When we're talking about mechanical ventilation, there's two important terms you need to know: volume and pressure. Si mde ka sommerize deux bagay sa yo, c'est nan deux bagay sa yo. It's a volume problem and pressure problem. So I'll break it down. So before we move forward, guys, we want to make sure you are familiar with some more medical terminology. Let us parler de tidal volume. Everybody knows what tidal volume are, right? What tidal volume is, right? Excuse me. Tidal volume is what I'm breathing in and what I'm breathing out, okay? When I'm breathing in, that's inspiration. And what I'm breathing out is what? Expiration. So tidal volume is the amount of air inhaled and exhaled during normal breath. So that's normal breath, and that's tidal volume, right? Okay. And what about if I were to define the FiO2? What is FiO2? Because in mechanical ventilation, you need to send FiO2. So FiO2, the normal FiO2, however, is 35 to 50%. Okay. And what is it? It's the fraction of inspired oxygen. And in other words, how much oxygen we are giving. Combien oxygène wap bay patient ki nan mechanical ventilation. It determines how sick they are. Okay? So that's FiO2. Combien oxygène map bay patient, c'est ça yo rele FiO2. Nou tout konnen normal breathing is what? Normal respiration is what? 12 to 20. Okay? Now, FiO2, we said it's the fraction of inspired air and how much oxygen we are giving. And the goal is as close to room air. And what is the percentage of room air? What I'm breathing right now. Parce que m'bag oxygen, m'bag tube nanem. 21%, right? I'm really missing my YouTube fans, my YouTube people, because oh, there you go. Sandra, thank you so much for joining. I need more people. Those of you that are shy, I'm so sorry for you because this is for you guys. Please put your name and say hi, say hello, please. Okay, and start sharing. Share the live. Besoin participation nou assoya. Pas vrai? Okay. All right. PEEP now. This is another terminology we want to understand when we're talking about mechanical ventilation. PEEP, EEP. This is an acronym. So first P means what is it? Positive. The first E is what? And the second E is expiratory, and the second P is pressure. So positive and expiratory pressure. And the normal of that is 5 to 8 centimeters of water. And what is that? What is that? So cela signifie si moun nan malade, est-ce qu'on connaît la besoin people it's gonna be higher or lower? Okay? What do you think? Well, it's gonna be higher. So the sicker they are, they need higher PEEP, which is positive and expiratory pressure, okay? And the goal of PEEP, okay, is to keep the alveoli open. Alveoli, c'est ça again, lungs one, that's what needs to, when you breathe, so if it's like filled of fluids or air, you're not going to be able to breathe properly. So you want to keep it open. So because that's the goal of PEEP, to keep the alveoli open. So more surface area, okay? More surface area for gas exchange. Gas exchange, so le n'a pas les, c'est ça, si m'ta bon mettre en nursing diagnosis for a patient, wap ban mwen ineffective airway breathing, or maybe impaired gas exchange. But what would be the medical terminology, guys? The medical terminology would be what? Maybe ARDS, COPD, asthma, or emphysema, chronic bronchitis, right? Respiratory failure and all that. So I'm sure you'll understand the difference between nursing diagnosis versus medical diagnosis. Okay, so now let's talk about ventilator modes. The ventilator modes, très important. Okay, the ventilator modes, gagne deux modes. Et deux modes, ça c'est ça que m'a dit, mechanical ventilation, li résumé en deux, vraiment en deux bagages ça yo besoin connaître. Qui deux modes ça yo? N'a parlé volume and pressure. So the first one we said is what? It's a volume problem. So what is it? What is it? Volume cycle ventilation. What does that mean? That is, guys, it's when it's a preset. I'm going to by definition après ça m'a expliquer. When a preset volume is reached, inspiratory phase ends, and that's for short term. What does that mean? Okay. So le moun nan, and d'habitude ça c'est pour moun qui pas vraiment capable de faire en première respiration. Moun ça li totalement dépend de mode ça. Okay, the volume cycle ventilation. And what is an example of that? Volume cycle ventilation is assist control mode. Wap aider moun sa respirer. What does that mean? So they set the ventilator at a preset respiratory rate. Plus yo mette tidal volume nan, pas vrai? Et puis après ça yo mette FiO2 que nous te expliqué ça the fraction of inspired oxygen, and that's how much oxygen you're giving. And the last thing, they add the PEEP. Okay, so that's assist control mode. So imagine a mode ça li pral délivrer, li pral buy seulement the set amount of breaths. So, si moun nan besoin 10 respiration, la bay exactement ça patient besoin. And usually this mode is for sicker patient. So, whether patient a respirer ou pas, c'est un volume quand on li set. Comme de abdo li fixe, it's a fixed mode. La délivrer precise, consistent amount of breaths for that patient. Okay, so that's what that is. So it will deliver a set amount of breaths to that patient, additional cycles that can be triggered by the patient. So imaginez, si m'ta pose question, patient ça, si ou bali consistent breath every time, so ou pense patient ça at risk pour ça. What do you think the patient going to be at risk for what? What if patients stop breathing, but you still deliver the same amount of oxygen every time? Don't you think you probably, or the patient will be at risk for too much oxygen? Yes. And that's what we call the risk for barrel trauma. Parce que wap bay patient, patient ka end up, ça son risque, okay? Son complication. Patient li ka end up getting too much oxygen. That's what we call too much support. Okay, that is a complication. So now in NCLEX, we understand the volume cycle ventilation. An example of that is assist control mode. Cependant, what is the risk or the complication? Actually, deux bagages are différents. Risque différent que complication. Si m'da do risk for assist control mode would be what? Too much support for that patient. And what would be the complication? The complication would be barrel chest trauma. Imaginez chest patient a gonflé, la gonflé trop. Qu'est-ce que vous pensez qu'il va arriver? Il va exploser. C'est exactement that's the problem with volume cycle ventilation. Cependant, moun qui besoin bagay ça, that would be a sicker patient, un patient qui pas capable de respirer pour compte li dépend de volume cycle ventilation. And nous by example encore ACM, which is what? Assist control mode. You guys get that? Okay? So that's your assist control mode under volume cycle ventilation. All right? So it says here, risk for barrel trauma, no matter what, the vent will add fixed volume pressure so it may burst the alveoli. There you go. So patient sa li pral end up explose or lung li ka just burst because there's so much you're giving, and that is assist control mode. The second type or the second mode que nous te dit, parce que nous dit your ventilator, it actually summarized in two ventilation really, or two cycle. What is it? The first one is volume cycle. An example of that is what? Assist control mode. And the deuxième ventilation, cycle ventilation, we call it pressure cycle ventilation. So he said the first one is volume. The second one is what? Pressure. So it's a pressure. Now just think of the word. I'm giving pressure. So that means what? What does that mean to you? So it says here for pressure cycle ventilation, of course, it says when a preset level is reached, the inspiratory phase ends. Look at previous preset pressure. So more due to compliance of lungs. Okay. So just example of that is what? Patient initiates the breath. So it's different. Okay. So example of pressure cycle ventilation. Patient li actuellement la aidé tête li respirer. Li prend premier breath là, whereas the first one, no, you are delivering consistent amount of breaths no matter what. But this one, the patient is less sicker. Okay, patient sa pas aussi malade. Li respire cependant li besoin or extra aide. So the patient will initiate the first breath, and you basically you will provide pressure support ventilation. That's what you call PSV. So you only apply pressure support ventilation. And what does that mean? And basically the patient will initiate the first breath. The vet will deliver support as needed. So si patient besoin plus, la besoin plus. But it's like this mode is like as needed mode, or comment on l'autre façon it's not fixed, it's on demand. This one is on demand. So preset pressure value, patient regulates their own respiratory rate plus tidal volume. Remember the first one, they need everything. They need their FiO2, they need the PEEP, they need their FiO2, they need the tidal volume. For this one, they will regulate their own respiratory rate plus the tidal volume. That's it. Okay, so now key risk problem sa. Maybe the patient will not get that much. However, ça pas un problème parce que il still a respirer. It's on demand. But on est capable de dire complication ça qui ont pas un problème, li pap gagne barrel chest trauma. The alveoli will not burst open. So this is for less sicker patient. Do you guys follow me so far? So on réviser. Deux modes. The first one, or two cycle. The first one is a volume cycle ventilation. The second cycle is a pressure cycle ventilation. So what would be the example of volume cycle, guys? ACM, which is what? Assist control mode. What about pressure cycle ventilation, which is the second mode of ventilator? What is it? Or cycle ventilation? It's a pressure. The pressure cycle ventilation. And I hope you put your answers. I don't see the answers on YouTube. Okay. All right. So we said it is a pressure, and the example of that is pressure support ventilation. You guys get it? Perfect. Okay. So now some other terms you need to know. What would be my goal as a nurse? What is my care? My ADPI? When we're talking about nursing care, it's really your nursing process, which is your assessment. What would you be assessing? What would you be, how would you diagnose your patient? We just gave you two nursing diagnosis, right? Versus medical diagnosis. So what would be your goal, which is your planning, and what would be your intervention? So it really depends on what's going on with the patient. That's what we have something called high alarm and low alarm. So high alarm, those of you who know what high alarms, sometimes on NCLEX, you're posing a question. What are some causes of high alarm and what are some causes of low alarm? Can somebody put in the chat? Put it in the chat. And I'm also going to put it, those of you in my group, you already seen this picture. Let me see if I could share with you the low alarm and high alarm. Can you, I don't know if they could help me sharing this high alarm, the picture, high alarm and low alarm picture. All right. Let me see if I can show it to you guys. But anyways, if you guys could just put it in the chat so I could see. Let me see if I could share. If I could share the picture. But anyways, high alarm. Qui sak pa cause ventilator have high alarm? Anybody? Guys, mwen nou pa ekri repons yo. So mpa we repons yo. If you guys could just put the answers. I'm going to attempt to share. I'm going to attempt to share the page, but so when it's high alarm, that means airway pressure exceeds the vent setting. That's what it is, first of all, okay? You have, let me see if I could go here. Where's that, the vent? It's actually on the screen, remember? That's the chest, not this one. Let's see if I could show it. Okay. Okay. Let's see. I'm trying to show you guys a picture. If not, I'll just tell you what it is. But anyways, so airway pressure exceed vent set. Okay. So remember, we need to fix the tube and we need to fix the setting when that happens. So what are some causes of high alarm? That was a question. So some causes, maybe the patient is coughing, right? You will hear a high alarm. What if the patient is gagging? If the patient is gagging, you will also hear high alarm. Or if patient has bronchospasms, that would be a reason for high alarm. Or if the tube is kanking, or if there is a lot of secretions, that will also make it happen. Or if there is thick secretions, or if there is water in the ventilator circuit, that's what would create high alarm. What about low alarm, guys? Some causes. Anybody? Anybody? Guys, I don't see the chat. I don't see those comments. Okay, let me see. It looks like I have some chat. There you go. There you go. Now I could see the chat. Okay. But I know I have other people. You guys refuse to put the answers. Please. I know soon you have to put the answers because you guys are going to see the questions and you have to answer. So let's see some causes of low alarm, guys. We said the tubing is disconnected. So question sa yo kon pose yo nan NCLEX sous forme select all that apply ou bien yo mette yo nan case studies. So please, you need to be cognizant. Ou pa vle bliye réponse sa yo. Okay? So the causes we said for low alarm, that means there is a low pressure and what is it? So basically the low pressure cause the patient not to achieve a good breath. That's what it is. So low alarm, we said what would be the cause? So the cause, the tubing is disconnected. There is a leak. And what happened? Patient is actually being extubated. Sometimes, let me see my phone, please. Sometimes the patient is actually disconnected by itself or something actually happened. Something actually happened. And then they get disconnected. So just so you know. Any other answers? Any other causes, guys? Any other answers, guys? Hello? Hello? Any other one? Okay. All right. I'm looking for some answers. There's also if the BiPAP or the CPAP are not feeding properly, that will cause low alarm ventilation, just so you know. Or the ET tube or the trach is deflated. That will cause a low alarm. Okay, so by the way, now, next question I have for you, please put it in the chat because I know you guys can type it in. This is another question for you. What is the difference? L'entendre parler de BiPAP or CPAP? Anybody knows? BiPAP, CPAP. Anybody knows what that means? BiPAP, CPAP. I don't see my friends, and I don't see you guys are texting. Please, please, please. My YouTube friends, my TikTok, and I know I'm new to TikTok. So, but this is our second week already. So please join and answer. So what's the difference? Ki moun yo mette nan CPAP, même la kay nou, parfois, moun nan ka besoin CPAP, nou pa même konnen. Nou ka gen fami nou ki besoin BiPAP, nou pa même konnen. Okay? Usually CPAP is for less sicker patients and BiPAP is for more sicker patients. Cependant, ki différence yo. Okay, so you need to understand the BiPAP and the CPAP, they both deliver different pressure, okay? The pressure is differently. You know, when you breathe, inhale and you exhale, that's normal breath. But some people, they're having difficulty with that, okay? So they need help with either breathing in or breathing out. So, sous besoin help breathing in, which is inhale, or breathing out, which is exhale, you're gonna need what, guys? Can somebody take a guess? Can somebody take a guess? You're gonna need the BiPAP. So la signifie ou pas qu'à respirer, breathe in, ou pas capable expirer. So ou a besoin aide. So n'a pas les moun kankou ki gagne, let's say, I would say if they have maybe asthma, okay, that's an example. Okay, let's say if they have respiratory failure, whether they have even neuromuscular problem. Now, you guys heard of MS or AMG, moun ki gen problem, yo pa ka respire, and they end up with a trach. That's neurological problems. So they're gonna need a BiPAP. They're sicker, right? And your CPAP is for less sicker patient. So basically, CPAP provide constant single pressure level. Okay, that's usually the first recommendation. Si moun nan pa malade en pile, but si moun nan li vraiment malade, la besoin BiPAP la. And what is the definition of BiPAP? It actually delivers two different pressure levels. That means li ede avec inhale and exhale. So now you guys get it, right? Okay, perfect. Okay, so now I do have to close this presentation. I have 5 questions for you. So prêtez attention à question yo. I have 5 questions for you. They actually on my email. I don't know if I can. I guess I'm gonna have to, because you guys are not putting your answers. So I don't know whether you are answering or not, or you're scared to answer. I don't know what's going on, but I don't know why you guys are not answering. So let's go. All right. Let me see if I can share. Let this. Let me see. I don't know if I can share. I wanted to share this quickly with them right here. There you go. Is there any way you can share that for me? Okay, the page is coming up to you guys so you guys could see. I'm going to share the page so you guys, it's just to help you guys to answer. It's actually on the email. There you go. And then you can share. Thank you so much. Can you guys see the answers? Can you guys see? Actually, not the answers. No, nous pas besoin de question. Réponse yo, c'est question yo n'a posé d'abord. Can you guys see them? I have no way verifying. I'm just gonna have to keep going parce que moi m'a travaille avec moun qui pas vraiment répondre. So m'pa konnen pour qui raison, but I'm just gonna keep going. Okay, there you go. Now my YouTube can see. It's actually just been projected for my YouTube. Now they can see. Okay, so let's read the first question. This is question number 4. But that is actually a first question. So we're just gonna go one by one, okay? A client on mechanical ventilation suddenly develops hypotension and tracheal deviation to the left, what is the nurse priority action? OK? On va poser question encore qui est très important. Guys, this patient just suddenly develops hypotension. You guys understand? The blood pressure just dropped. And patient has a tracheal deviation to the left. So what is the nurse priority action? Let's look at the options. Number 1, increase FiO2 to 100%. I hope you guys were taking notes. B, prepare for chest tube insertion. C, notify the healthcare provider. And D, disconnect the ventilator and provide manual ventilation. What is the answer, guys? You can put your answer, guys, in the chat so I can see. I really need your participation here. Or else you just, and I understand you probably don't know the answer, but I'd like you to take a good guess, at least. Take a good guess. Qui sa réponse là est? Patient mechanical ventilation and suddenly it drops to hypotension. Blood pressure patient descend and you see you're looking at the trachea, it's actually shifted to the left side. So what is your nursing priority action? First, would you increase the FiO2? Qui sa noté dit définition de FiO2? Qui sa noté dit définition FiO2, guys? FiO2. FiO2, we said that was a fraction of inspired oxygen. That's how much oxygen we are giving to the patient. That's between 35 to 50%. And that is the normal, okay? And prepare for chest tube. Will you do that? Is this an emergency? C, notify healthcare provider. Would you call the doctor now? And the last option, disconnect the ventilator and provide manual ventilation. Mwen pa wè réponse yo, monsieur, dame. Mwen pa wè réponse yo. Mwen pa wè réponse yo. Mwen pa wè réponse yo. Last week, mpa konen gen lè go bagay ki pa marché nan YouTube la, or why I'm not seeing those answers. I am not able to see people answering. What is wrong? Before I give you guys the answers. Okay, the answer is B. Prepare for chest tube insertion. And the rationale is tracheal deviation and hypotension suggests a tension pneumothorax. It's a life-threatening complication of mechanical ventilation. It's an emergency. Decompression and chest tubes insertion are priority interventions. Do you guys see that? You see why B is the answer. Patient has what? We said what? Tension pneumothorax. Okay, so let's move on. Next question. A nurse is caring for 4 clients on mechanical ventilation. Which client should the nurse assess first? Which client should the nurse assess first? A client. Okay, we said the nurse is caring for who? The nurse is caring for 4 clients on mechanical ventilation. Which client should the nurse assess first? A client with bilateral crackles and SpO2 of 92%. B, a client whose low pressure ventilator alarm is sounding. Remember, we just gave you guys the causes of low pressure and high pressure alarm ventilation. C, a client receiving sedation with stable vital signs. And D, a client with PEEP of 5 and FiO2 of 40%. So I gave you guys the normal FiO2 and I also gave you the normal PEEP, right? The normal PEEP, remember we said it was what? Between? You guys forgot? 5 to 8 centimeters. And then FiO2, 35 to 40 to 50%. Okay, so now what is the answer, guys? What is the answer? Mes amis, m'a pensé last week, me posé question qui était très facile, c'est ça que fait me gagner plus monde répondre, bon jodi a c'est gros tontonnet, gros bagay, mais messieurs dames yo pas vle répondre même, yo pas prendre réponse yo. C'est voilà pourquoi moi choisi pour me capable parler de sujet ça yo. Parce que sujet ça yo advance. And that's when you actually go to critical care med surg 2, advanced med surg. That's when they really talk about mechanical ventilation and chest tubes. So voilà pourquoi nous avons du mal pour répondre. But si bagay déjà discuté, presented before, those of you who are on my, those of you who are in my class, nous même qui dans classe déjà, nous songez? So what is the answer, guys? What is the answer? Hello? Hello? Bata de réponse là, non? Participez, mes amis, participez. Participez. Répondre. No? What is the answer? Okay, the answer is B as in boy. B as in boy. Okay, B as in boy. A client whose low pressure ventilator alarm is sounding. Okay, and that is B. What is the rationale? We said a low pressure alarm may indicate disconnection or a leak, c'est ça noté dit tout à l'heure, in the ventilator circuit, posing an immediate risk to airway patency and oxygen delivery. This client should be assessed first. You guys see? Nous va mettre position sur pas capable voir qui ça nous choisi, qui ça nous gagne penser nous, but c'est ça réponse là. Okay, next one. A nurse is caring for 4 clients. We just did that one, right? Okay. The nurse is assessing a client readiness to wean from mechanical ventilation. Which of the following findings support weaning? Select all that apply. The nurse is assessing a client readiness to wean from the ventilation, right? Which of the following findings support the weaning? A PO2 or FiO2 ratio is greater than 200. B, respiratory rate of 32 breaths per minute. C, tidal volume is 6 ml per kilogram. D, no sedation for 12 hours. And E, negative inspiratory force of 25 centimeter of water. Negative 25 centimeter. What is the answer, guys? Select all that apply. Anybody? You guys, if you're not responding, you probably want to go on YouTube so you can answer, because I don't see you. Yes. Welcome, Charlene. Welcome. Just answer. Just answer. Just put your answers. Put your answers, guys. At least one. Mettez réponse yo. Bon, regardez si mettez. Parce que je ne peux pas voir dans computer pas si nous mettez chat là. Maybe you guys put the answers, but I cannot see them on YouTube. Je ne peux pas voir on TikTok non plus. Cependant, the answers, I hope you're writing your answers. You ready for the answers? A as in apple, C as in cat, D as in David, and E as in egg. So the answer is PO2. So nous dit qui sa patient gagne qui fait li prêt pour capable sortir dans ventilateur. That's the question. A nurse is assessing a client readiness to wean from mechanical ventilation. So which of the following findings support the weaning? Qui sa indique patient prêt pour capable sortir dans ventilateur là, which is the life support, pas vrai? So that means the patient is doing better, pas vrai? The PO2 and FiO2 ratio is greater to 200. And B a pas là-dedans parce que respiration nous connaît est tombé. The normal respiratory rate is what? 12 to 20. So this respiratory rate is 32. That means patient is not ready. But tidal volume is 6 ml per kilogram. You guys know the normal tidal volume, right? Who knows the normal tidal volume? Normal tidal volume per kilogram is 6 to 8 ml per kilogram. So this patient is 6 ml per kilogram. That's why this is one of the reasons that patient is ready to be weaned off from ventilation. And no sedation for 12 hours. You know, they have to sedate them because your bataille, your tap retirer comment tube ça, si vous êtes capable, si vous êtes pas sedated, si vous pas en bas contrôle. So voilà pourquoi, si patient pas besoin sedation for 12 hours, that means you're ready to be weaned off. And then the last one, we said negative inspiratory force of negative 25 centimeter water. So that is the answers, guys. And then the last question, a client on mechanical ventilation has a high pressure alarm sounding. The nurse assesses the client and finds them agitated and coughing. What is the most appropriate action for the nurse to take? So wale checker where patient get mechanical it's on mechanical ventilation, and what is the patient is doing? The patient is agitating. The patient is fighting, right? The nurse assesses that client finds them agitated and patient is coughing. So what is the most appropriate action for the nurse to take? Okay, you guys understand the question? Now let's go and look at the options. Okay. A, suction of the ET tube. Should the nurse do that first? What is the most appropriate action? Whenever you ask you for action, that means intervention. They're not asking you to assess. They're not asking you to plan. They're not asking you to evaluate, but they're asking you to do what? They're not asking you to diagnose either, but they're asking you to intervene, which is implementation and and also acting. So should you suction the ET tube? Should you silence the alarm and monitor the client? C, should you administer a sedative as prescribed? Or should you reassess the ventilator setting? What is the answer, guys? That's the answer. Bonne réponse, s'il vous plaît. What is the answer? Hello? Nou pa ka repon? Claudine nou la, m'batade nou, Marie. M'batade nou pa repon? Okay. The answer, guys. What is it? The answer is C as in cat. Okay? Patient la cough, patient agité, and we said the client is on high pressure alarm. Actually, patient is on mechanical ventilation, but there's a high pressure alarm. And remember, we said the causes of high pressure alarm, one of them was what? Coughing. And if patient is agitating, of course, you'll hear the high alarm. So now what do you do when you hear a high alarm? You need to administer a sedative as prescribed. Si vous pas faire ça, patient va agiter plus, il ka même déconnecter, il ka même mourir. Okay? So, of course, you're not going to suction. You're not going to silence. Of course, you will silence the alarm, but you could do that later. Okay? And what else? Reassess the ventilating setting. You could do that later. So then this is the rationale. Agitation and coughing can cause increased airway pressure, triggering a high pressure alarm. Administering a sedative helps reducing patient ventilation dysynchrony. Suctioning may not be necessary if there is no evidence of secretions. So superware suction, why should you suction the patient? So you need to the best thing to do, calm the patient down, okay? So that ends, I only had 5 questions on mechanical ventilation. And I hope you guys going to review the video over and over and be able to grasp the concept, because I know it is a critical care concept, and hopefully you guys were able to get that concept. Okay, and now I am moving on to our next level. We are done, okay? All right, perfect, Nikki, great job. I was not able to see your answers. And I don't know, I see Charlene also answer A. I saw Nikki also answer A, but I wasn't able to see for which question. But anyways, great job. Great job, you guys. Now let's go to my other favorite. And as I said, that's what I was going to introduce to you guys. I hope you could see my chest tubes. Okay, that is the next presentation. Chest tubes. So when I'm talking about chest tubes, guys, again, it goes hand in hand avec mechanical ventilation. Parce que d'habitude, des fois, you're on mechanical ventilation, and before you know it, and you're gonna see what they need. If they do something or depends on vital signs, they're gonna need chest tubes. So having said that, now, who needs a chest tubes? And how many types of chest tubes we have? Okay, so qui moun qui besoin chest tube? Nous connaissons ka wè réponse yo, mettez réponse yo pour moi. Qui patient, est-ce que nous capable boire chest tube moi? Quand on va battre plus explication. So qui moun qui besoin chest tubes? On regarde si m'était capable retirer ça. Oh, m'pas capable retirer. Let me see. Okay, but I need to see your answers. Okay, so qui moun qui besoin chest tubes? Why do I need chest tubes? Remember earlier I mentioned about atelectasis and pneumothorax and hemothorax. So these are 3 different medical terminology. So what is the difference between hemothorax and pneumothorax? Just a quick review, guys. Mettez réponse là vite pour moi parce que you guys heard it already. Mettez réponse là pour moi. The difference between hemothorax, pneumothorax, and atelectasis. You guys know atelectasis. I don't know if you want me to type it for you, but you guys know that word, atelectasis. Let me see if I could type it in. Okay, atelectasis. I hope I spelled it correctly. Medical terminology for you. M'apprendre nous mettre réponse là, c'est peut-être ça ouais m'apprendre tout le temps ça oui. It's A-T-E-L-E-C. You see, they mette L-A-S. It's L-E-C-T-A-S-I-S. There you go. Now I'm going to send it to you. So what's the difference? Atelectasis. We said that's partial lung collapse. And pneumothorax is complete lung collapse. And then we also have hemothorax. So hemothorax is when you have what? Blood in the lungs. And pneumothorax is what? Pneumothorax is air in the lungs. So now, question de ka pozo avant moi introduire ça à ou même. A chest tube is placed in a patient for hemothorax, which is what? Patient has blood in the lungs. What would you do as an LPN or as a nurse? What would you report to as an RN? Of course, the RN would be, the LPN would report to the RN. Parce que this is a complex procedure. Just so you know, patient qui gagne chest tube mechanical ventilation, yo pas pour LPN. Tant pis pour moi, m'pa vle nou penser que LPN capable prendre soin bagay sa yo. Okay? So, patient qui gagne mechanical ventilation, chest tubes, and of course, even if they were to work under the RN, but they have to report to the RN. So, si patient gagne hemothorax, which is blood in the lungs, so as an RN, what would you do? What would you report to the doctor? Would you say chest tubes is not bubbling? B, would you say chest tubes drain 800 ml in the first 10 hours? Would you say chest tube is not draining? Or would you say chest tube is intermittently bubbling? Patient gagne qui sa blood in the lungs. what do you supposed to see in the lungs, in the actually chambers? Blood, right? So the answer is what? Chest tube is not draining. Yes, the chest tube is not draining. Nous me poser une question ça même avant m'introduire the whole concept. So when you have someone on who has a hemothorax, you're supposed to see blood draining in the chest tubes. And let's say if the patient has pneumothorax now, that's air in the lungs. So what do you supposed to talk? What are you supposed to report to the doctor? Chest tube is not what? Chest tube is not bubbling. That's what you're supposed to see. Simon na say air lige in the lungs, ou pa pral wè blood in this collection chamber. Okay? You should see air. So having said that, m'gale introduire à nous-mêmes concept chest tube là. Okay? Ba m'gade si m'de kwa montrer photo chest tube là quickly and show you guys quickly the types of chest tubes. There's different types of chest tubes, but this one I'm gonna talk about. This is Yaleris. Can you help me share so they could see? I hope my picture is clear enough. You guys, yes. Okay, I'm going to show you now the chest tube. No, this isn't, I guess this is share. Okay, right here. Hold on, guys. I just want you to see my picture so you guys could see. All right. And thank you for your patience. Chest tubes right here. There you go. Okay, perfect. Now, hold on, but I don't see my group. Let me go right here. There you go. Perfect. Okay. So now I just show you guys this company called Aleris. The Aleris, actually not Aleris. Aleris pump is for another one, but this one is Atrium. Atrium is a company that also produce chest tubes. Now again, lot company qui produit, but this one ou capable de différence. So this is two different chest tubes here. Now, one. Regardez yo chaque way yo différent. Yo tous les trois gagne something called 3 chambers. Each one of them has 3 chambers. The first chamber, let's say this one. I hope you could see mine. That's why I bring mine. Okay. The first chamber, this is now, before I even talk about the chambers, let's talk about the types. That we have one for dry suction and also one for wet suction. And that's what really create the suction. Parce que qui sont pral suction? Either the air, si mon gen pneumothorax, ou pral chest tube là, c'est pour capable absorber air dans poumon moun nan. That's what you call suction. And also wet suction, ou besoin de l'eau in order for suction to occur. So one, the dry suction, you don't need to add water in this tubing in order for suction to occur. But if, if you're talking about wet suction, they need to provide water to add at least 20 ml, and I'll show you where they need to add that water, sterile water, in order for suction to occur. So then each of them has 3 chambers. Each of these, when we're tous les deux, you're different. The first one, I'm gonna go by here. You see the bigger one? It starts from 200 ml all the way to what? 1200 ml. That is what you call a collection chamber. And as a nurse, when you come in the morning, you're starting your shift, it's important for you to mark where you start. Très important, especially si patient fin sorti dans operating room now, it's important for you to monitor how much blood is coming out, how much drainage, or if it's a pneumothorax, how much air, how much bubbling do you see, or you don't see bubble at all. So it's very important for you to check the collection chamber. Okay, so the second chamber, that's what you call a water seal chamber. Et nous capable voir ça aussi dans photo. This is a wet suction. Après ça, on va parler de dry suction. So the water seal chamber, you can aussi mettre de l'eau là. And then this is what we monitor to see whether it's you see vigorous bubbling or something called gentle bubbling. And the other name for that, anybody? So mettre the name for me. What is a gentle bubbling called, guys, in test questions? Tidling. You guys remember? Sorry. I'm trying to put in the chat. Hold on a second. Tidling. I was trying to type it for you. Tidling. Tidling is what you call gentle bubbling. Okay? Gentle bubbling. And what type of bubbling we're supposed to see in the water seal chamber, which is the second chamber? Gentle bubbling, tidling. That's what you should see. And whenever you see vigorous bubbling, that means there is something wrong. Either there is something is disconnected, the tubing is kink, it's like it's clamping, something is wrong. So très important pour checker là pour so vigorous bubbling, okay? But you're supposed to see gentle bubbling at all time. Okay, and then the third chamber on the wet suction, we call it, this is where the suction will occur because this is a wet suction device, okay? And then you also have the tubing that's connecting up here, right? Okay, and then you also have this part here. That's what is actually connecting to the site of the patient, to the surgical site. You see the tip of it? So if any case this is disconnected, you're gonna have to take this and do what? You immerse it underneath or beneath sterile water to create suction. And what do? You tape the surgical site. And we said you have to tape it. How many borders, guys? With 3? Do you tape all the 4 borders? Remember, it's a sterile, what is it? What do you apply, first of all? Sterile occlusive dressing. Okay, cela signifie ou pas quitter l'air pénétrer en dedans patient. And also, while that happening, you cannot also air to come in and air is not coming out. Okay, so that's why we only tape 3 borders, not 4. Okay, très important. That's the test questions. And what I just said with this, immerse this under sterile water below. It has to be beneath the water. Okay, that is also another test questions. Okay, and now let's talk about the dry suction. It also has 3 chambers, same as this, guys. The only difference, you see, the first one we said it's the same collection chamber. And in the morning whenever you start your shift, you need to make sure you mark it. Très important. Okay? And the second one, you're gonna have, it's the same as the first one. Water seal chamber. And then the last one, you're not gonna see water in there, but you're gonna see a orange, we call it a bellow, and it's going to move back and forth like this. Et c'est ça qui crée pressure. Okay, that's what creates a pressure. And usually it comes from the OR, the doctor preset it for you. Ou pas besoin allemand. C'est pas ou même qui, that's not your nursing responsibility. That's not under your scope of practice. It comes ready for you. Sometimes you'll see it under maybe negative 45 millimercury, whatever the doctor wants the setting to be. That's what it is. Okay, again, it's the same concept as questions under the water seal chamber. As a nurse, what is your role? What is your expectation if you see vigorous bubbling in the water seal chamber? Right here, guys, in the water seal chamber. If you see vigorous bubbling, what do you do? How do you troubleshoot, guys? Hello? You guys could put the answers for me at this time. Well, it really depends what happened. Si c'est déconnecté from the surgical site, we will tape it with a sterile occlusive dressing and make sure the tip is beneath the sterile water. And if it's disconnected here, up here, we would have to put it back and tape it, just so you know. All right, right here. And if it's like this one is fall like this, make sure you have it sit. Make sure it's sitting properly. But si patient a parfois elle a bougé, or if patient is moving, sometimes it will alarm as well. Okay, you will hear it. So just so you know, it's important that you troubleshoot. But first, you always assess your patient. So NCLEX always wants you to assess your patient first. That's always the number one. No matter what is going on with your patient, ou pas besoin connaître. Faut capable ouais, est-ce que patient okay? Est-ce que patient symptomatic or asymptomatic? Qui symptôme away, then you know something is wrong with your patient and how to troubleshoot, how to help the patient. It's just like, for example, quand vous si on du patient, qui ça, la prend insuline, et puis, ou un patient, li confused. So, example, all of a sudden, you were in Mrs. Patient, or what is it? Mrs. Johnson's room. She was okay. And like 15 minutes, you came back. Patient is confused. But before you call code blue or a rapid response, well, patient is confused. You're not going to call code blue, please. You're going to call rapid response. But before you call rapid response, you need to look at your patient. And first, before you call by patient, glucose, 50% of glucose, what are you going to do first? Check the blood sugar. No comprendre? So, c'est même bagay la. So, si patient ou est gon bagay ki wrong with your patient, you need to assess your patient. Always assess your patient first. No matter what is happening to your patient, you need to take a look at your patient. So, it's the same thing. Telemonitor, you di, oh, patient gagne SVT, ou bien patient gagne, what is it? VTAC, pulseless VTAC, or defibrillation. You avant ou rapid response, assess your patient, check your patient, okay? Très important. Est-ce qu'il y a une question so far dans chest tubes yo? Okay? Non, très important. Si patient sorti dans OR, okay? And the first 12 hours, you guys know the patient is very unstable. Now, how much drainage do you usually expect to see in the chest tubes? Ma ba nou tan pou nou repon question sa. Okay? Ma ba nou tan pou nou repon question sa. Before you call the doctor, how many ml you're supposed to see in the chest tube before you call the doctor? What prompts you to call the doctor, basically? In the collection chamber. Mettez réponse pour moi, tant pis. Et puis, where it's bright red blood in the collection chamber. What is a margin? The normal output, guys. Especially the first hour. Hourly. You know, Saunders actually has a question like that, guys. Saunders has a question like that. It says a maximum fluid drainage of 1 to 1.5 liters per hour is recommended to reduce the risk of re-expansion pulmonary edema. This is for drainage, but for the chest tube is different, okay? We don't want it to be 100 ml above, right? We don't want it to be 100 ml above. So make sure, oh, I see more answers. Great job, yes. Great job, 100 ml per hour. We don't want it to be above that because that's trouble, especially if it's bright red. That's called trouble. And I know there is a question on Saunders. It says we want it to be between 50 to 70, right? And that's normal. But anything above 100, that's called trouble. We don't want that. Great job. Great job, boss. AIB. I see that. Great job. Great job. Thank you. Okay, now, do you have any questions about chest tube before we do some questions for you? Okay, I have some questions. So we talk about, let's quickly review. We said there's two types of chest tubes. One depends on what the doctor chooses. They may place patient on a dry suction, or they may choose a wet suction. And the difference between a wet and dry suction is just a matter of what? We said first it's a physician's preference, but what is it? One needs water in order to create the suction. That's what you call the wet suction. And the dry suction, it doesn't need water in order to create suction, all right, for it to work. And we already know as a nurse, depends on what happens to your patient. If the tube, like this part right here, if it's disconnected from the surgical site and you see the dressing is off, right? We're going to quickly immerse the tip into it, right? Into the sterile water in order to create suction. And then we tape the 3 borders. And then if it's disconnected right here, we got to tape it, okay? All right, and then what else we said? I think chest tube is very straightforward. Now I have some questions for you. Hold on, please. Let me see if I could share those answers with you. Is there any way you can help me, please, sharing? Yeah, that's the one. I'm going to share the questions with you guys in a little bit. Okay, right here. Right here. So I got 5 questions coming up your way. And then after that, we will be done with the live. Just bear with me a little bit. And thank you for your participation. Right here, the first one. Thank you. Perfect. Okay, just bear with me before you see the answers. Okay. Oh, look at that. You guys are participating. Now yes, perfect. Okay, so the first question. A client with the chest tubes following a thoracotomy complains of severe pain at the insertion site. Upon assessment, you notice subcutaneous emphysema around the chest tube site. What action should you take first? Again, you always want to read your question not just once, not just twice, but until you understand it into your own language, whatever language you speak. A client with a chest tubes following a thoracotomy complains of severe pain, okay? And look for the keywords, severe pain at the insertion site. Upon assessment, you notice subcutaneous emphysema around the chest tube. What action you should do first? A, administer analgesic as ordered. B, notify the healthcare provider. C, document the findings in the chart. And D, tip the chest tube securely. What is your answer? Boss, B, AIB, Shirley, Nikki, Sandra, or others that are not responding. My TikTok friends, what are your answers? Yes. Oh, TikTok is actually responding. Great job, TikTok. I want to say welcome to Mimin. Mimin, thank you for joining us. Okay. What do you guys choose? Your first question. I haven't seen the answer. Okay, I see some answers. Great job. I see D. I need more answers. More people, please. Participate, guys. Okay, I see somebody put C. Is that what you said? C as in cat? I see D as in David. Okay, is that all? Okay, you guys ready for the answers with the rationale? All right, let's go. Let's share the answers with the rationale. The answer is B as in boy. You need to notify the healthcare provider. And here is the rationale, guys. Subcutaneous emphysema, guys, indicated by the presence of air under the skin, can result from a possible disconnection or leak in the chest tube. This is a serious complication that requires immediate attention to prevent further complication. The healthcare provider should be notified promptly to assess and address the issue. So understand, even if you never heard the question, you never heard of the question, but the keyword here, let's see some keywords. You hear severe pain. That's not normal, because anybody with its insertion site, even if they had a biopsy, you would expect them to have some pain, but not severe pain. Whenever you hear severe pain, that's abnormal. That's not normal, first of all. And then you hear subcutaneous emphysema. Subcutaneous emphysema, that is not normal, because it indicates there is a presence of air underneath the skin. So that's how you already know something is wrong with your patient. And you're not going to administer pain, which is option A. First, do you have an order? They didn't, even though patient has pain, but this is not your priority, okay? Number C. C says document the finding. No, that's always last. You don't have time for that. You do that after you're done, after you're taking care of your patient, right? And then D, tip the chest securely. This is not, we don't do that. It's not disconnected. The tube is not disconnected at the surgical site, like I showed you earlier. This is not disconnected at the surgical site. Okay, so now next question, number 2. While caring for the client with a chest tube, you observe continuous bubbling in the water-sealed chamber of the drainage system. What action you should take? A, of course, you want to read it again. You're caring for a chest tube, you observe continuous bubbling. Nous sommes de parler de continuous versus gentle bubbling in the chest tubes in the water-sealed chamber of the drainage system. What action should you take? A, clamp the chest tube. B, increase the suction pressure. C, document the finding as normal. And D, check for air leaks in the system. Okay, I see some answers coming up. C as in cat, I see somebody put D. I need more answers, guys. Let's get it rolling. Great job. Let's get it rolling. While caring for a chest tubes, you observe continuous bubbling. Qui ça nous te dit pour faire? Lower continuous bubbling, that's you need to troubleshoot pour faire un bagay. Parce que li signifie un pile bagay. Li signifie peut-être patient a bougé, peut-être patient et comment the tube is kinking ou bien ça capable il pas open, you see? Right here, the clamp is like, maybe that's why that happens, or there is a leak somewhere. So what do? Clamp the chest tubes, increase suction pressure, document the findings. We know that has gonna be last, and check for air leaks in the system. The answer, you guys ready for the answer? The answer is D as in David. Great job. Those of you who said D. Check for air leaks. Here's the rationale, guys. Continuous bubbling in the water-sealed chamber indicates an air leak in the chest tube system. This can lead to inadequate lungs re-expansion and improper drainage. Checking the system for air leaks and properly addressing them is essential to maintain proper function of the chest tubes. Yes, air leaks. Cause that. Number 3, I got 2 more questions after that. I only have 5 questions here. Okay. All right. Number 3. Here we go. A client with a chest tube accidentally pulls the tube out while turning in bed. That happens sometimes. What should you do first? Again, a client with a chest tube accidentally pull the chest tubes out while turning in bed. What should you do first? Number 1, place an occlusive dressing over the site. B, call the healthcare provider immediately. C, assist the client into a high Fowler position. And D, quickly reinsert the chest tubes using sterile technique. What do you do? And we talk about that. The chest tube is accidentally pulled where? While the patient was what? Turning in bed. What should you do? Do you place an occlusive dressing over the site? Do you call the healthcare provider? Do you assist the client into a high Fowler position? Or do you reinsert the chest tube using sterile technique? I see some people put A. Some people put A. Okay. All right. You guys ready? Is everybody agreeing? I don't see all the answers. But the answer, let's see, is A as in apple. Place an occlusive dressing over the site. That's what you should do. You guys already know, it says here, if the chest tube accidentally dislodged, the priority is to prevent air from entering the pleural space, and placing an occlusive dressing over the sites help to create a temporary seal, prevent the development of tension pneumothorax, which is very bad. And the healthcare provider, you should then be notified, and chest tubes should be reinserted as soon as possible. Okay? All right. Okay, number 4. While assessing a client with a chest tube, you know that the drainage system is knocked over, causing the tubing to disconnect from the collection chamber. What should you do first? From the collection chamber now is disconnected, guys. What should you do first? A, reconnect the tubing and secure with tape. B, assess the client respiratory status. C, lower the collection chamber below the client chest. And D, replace the entire drainage system. What is the answer? Come on, guys. Put your answers. You're doing great. Put your answers. Mettez réponse. Allez, puis share the live. Partagez, partagez, partagez. Mba we réponse yo, no? Mboko we réponse yo. A, you have some people say A. Reconnect the tubing and secure with tape. Okay. Do you replace the entire? That's the answer. A. Reconnect the tubing and secure with tape. And the last question here. A client with chest tube complains of pain during coughing and deep breathing. What intervention should you recommend to help alleviate the client discomfort? The client complains of pain during coughing and deep breathing. How would you, as a nurse, alleviate the patient discomfort? A, administer an additional dose of pain medication. B, encourage the client to splint the chest with a pillow. C, increase the suction pressure on the drainage system. And last, D, instruct the client to avoid coughing and deep breathing. What are your answers, guys? This is the last question, and we'll be done. It's almost done with our live for today. Okay, what's the answer? This is our last question. Did you say B? I see B. I see B. All right. The answer, you guys are great, is B. Encourage the patient to splint the chest with a pillow. Will do what? Will help to provide support and stabilize the chest during the coughing and deep breathing, which can help alleviate pain, discomfort. This technique helps minimize movement of the chest and reduce the strain on the incision and chest tube site. Perfect. So that was really great, guys. Let me now get out of the site. Great job. Great job. And thank you all for your participation. Thank you. Mon qui te vini yo, merci beaucoup, m'apprécier ça. So again, today we reviewed 2 critical concepts: mechanical ventilation and chest tubes. M'souhaite, and I hope after today, any questions you would have on chest tubes or mechanical ventilation, you would do very well. You can review the slide. And also, guys, in addition to that, I do have a special Kindle version for 2. One, if you were to go, I don't know if I can show them. I don't know if I can show them. Maybe, hold on. I'm going to see if I could show you guys. It's available for you guys on Kindle version. If you go to Kindle version, I'm going to send you the link. Is there any way I could share the link with them, please? So they could see if whether you need it on, you could get it on Kindle version and you can have access to it so that if you need to order it or you need to see. Okay, quickly. Okay, my manager here needs to. Okay, basically, if you go to Amazon, you could put my name, and for either chest tubes or mechanical ventilation, and you guys should see. Put Christine Jean-Léon, and also you'll see other skills. And my plan is to put as many skills as possible, especially the most difficult one. So there's also test questions with those, how to do, what not to do, some nurses' experiences, what went wrong, how they troubleshoot. It's something that you can print. I don't have it in a book version. But what I have in a book version, guys, for NCLEX prep is what I introduced earlier, is my volume 1 and volume 2. My volume 1 is here with me. My volume 2, I ordered. It's coming the next week or so. And the volume 1, it's NCLEX Master Review. Volume 1, what is that? This is the whole blueprint for NCLEX. You guys know when you guys go sit for your NCLEX, and then they said, oh, Jean, your neopath psychosocial section or managed care section or maternal health, or there's another section, basic care comfort, which is most people don't pass basic care comfort because they think it's too easy. They don't remember how to make a bed. They don't remember how to prepare a dead body for the morgue, or and what to do, vital signs, things like that. So this has all the blueprint, step by step, definition, explanation, and also it's backing up with questions for each chapter. Each chapter you'll see at the end maybe 10 questions, but each concept also has a question to support it. Addition to that, guys, I have 100 questions on critical care questions and 200 questions as bonus on most missed questions on NCLEX. And also we have medical terminology as well as critical care concepts, prioritization, delegation, you name it. I give you everything, more than what you bargained for. And volume 2 now, it's all the 10 types of NGN, okay? We're talking about the bow tie, the matrix. Pas vraiment, gon seul livre moi konnen qui fait comme ça, yo pas même détailler all the 10. My book is like the first one, guys, to break down all the 10 types of NCLEX. So just so you know, you're getting more for your money, and the price is really for 2 for 1. When I compare, because I put the price online just to compare the prices, comparing to Saunders and other books, I was told the price, mine was like kind of the lowest, but I'm giving you guys 2 price for 1. It's $49.99 for each, and a total $99 or $100 for both. So if you need to order, please, you need to get the set. You can't just get one. I have the set. Also, if you need classes online, I do offer classes online, but I need 10 people to do that. So if you know your friends, you're getting ready for NCLEX, get 10 people. My number, I'm going to put my number in the chat here, and text me, call me, and get me 10 people, and then we could get a class rolling. But this live is very important, and I will continue to do it because that also help with the case studies, questions and answers, difficult skills you need to understand, you need to explain. I will do all of that for you. By the way, I'm an educator. I have my master in nursing education. All my my masters are in nursing education, as well as I'm currently doing my PhD at Barry University on research. researching what are the barriers, the immigrants, especially the Haitian population, why they're not passing their NCLEX. And it's not just language, but I need to find out why and create a program. So I want to help you guys. I want my community to be successful, as well as whoever wants to join. I am here to help you. That's my goal. So the best nurse God wants you to be, that's what we want to develop from you. We want you to be the best nurse God wants you to be. Okay. So just so you know, tell your friends. We will meet again next week, the same time on the live. So have a wonderful week. Unless you have any questions, put your questions in the chat or call me. But that's it for today. Thank you so much for your support and your participation. You all did a wonderful job. Nous fait très bien. Et merci beaucoup. Et maintenant, appelle-nous. Bye. Have a wonderful week. And let's have a word of prayer. Father God, once again, I pray and I want to thank you for making this live possible, even though we've gone a little over our time, but it was all worth it. I would like to ask you to bless all the students that are on this platform, whether they're waiting to pass their NCLEX, whether they're in nursing school, they are getting ready for their exams, they're in nursing school, or they're entering their nursing first year or second year, whatever the case may be. I ask you to bless them, bless their family, augment their intelligence, give them wisdom from above, and help them to be able to be ready when the time comes to pass their NCLEX. They'll be able to pass with flying colors, Lord, and also those that are still in school to be able to pass their exams, every exam, so they could make it to graduation. In Jesus' name we pray, amen. Bye, guys. Love you. See you next week. Next Sunday, tell your friends and share the live. God bless. Bye. Thank you. No problem. You're welcome. Bye-bye. End stream.
Watch what eggs do to your old dog's body.
Raw egg or cooked egg? It doesn't actually matter. Eggs are great for dogs, so add it. Apples or grapes? Grapes are toxic for dogs. They can literally go into kidney failure if they eat grapes, so toss those. Add apples. Turmeric or cayenne? Cayenne is not good for dogs. Turmeric, on the other hand, can actually have anti-inflammatory benefits for a dog. So yes, add just a sprinkle of turmeric. Salmon or chicken? Salmon is amazing because it's packed with nutrients, especially healthy fats, but it can be a little expensive, so chicken is just as good. What about kibble or wet food? Neither. Kibble is often cooked at such high temperatures that it can remove the nutrients and produce something called AGEs, which can wreak havoc on your dog's health. Wet food is also highly processed, which leaches food of nutritional benefits, but more alarming, the cans have high levels of toxicity. I have a third option that is super simple and can help with itchy paws, mushy poop, and bad breath. But you have to be careful. There are certain spices you may love but can give your dog nausea, organ issues, and sadly, even be lethal. Never feed your dog these. Toxic dog spice number 1, cocoa powder. Most people have heard that chocolate can be harmful to dogs. Actually, a dog would need to eat a lot of milk chocolate to get sick, but just a little cocoa powder can cause vomiting, seizures, and even death. Keep cocoa powder away from dogs. Toxic dog spice number 2, pumpkin pie. Pumpkin pie spice contains nutmeg, cloves, and allspice, and all 3 of these are toxic to dogs. So especially around Thanksgiving, a lot of people might feed their dogs some leftovers. Definitely skip the pumpkin pie. Toxic dog spice number 3, cayenne. Okay, cayenne pepper isn't technically toxic, but if a dog gets a big whiff of cayenne, it's gonna burn their eyes, their nose, their throat, and if they eat it, it can cause all kinds of stomach irritation. So if you're making a big batch of chili, keep the lids tight on all your spices. But here's the craziest part of all. These 3 spices are dangerous to dogs, but there's a few spices that are the exact opposite. Feeding your dog what I call canine super herbs can have a major impact on their health. There's herbs that can help with itching, with joints, with energy. There's herbs that can help improve motion sickness. There's herbs to help promote calm moods, and even herbs that support organ health, so your dog can live a happy, healthy life. Okay, let's talk about which herbs you need to add to your dog's bowl to help them look and feel fantastic at any age.
Hi, excuse me.
Oh, hi.
Beautiful dog.
Thank you.
How old is he?
He actually turned 12 this year.
12. Wow. Look at him. He has so much energy. Which of these dog foods do you feed?
Actually, not any of these, but we're just here to get a new toy, which obviously we have a winner.
But you must do like something.
Here is how I got rid of my sore feet and my swelling for good. I did a ton of research, guys, on the best way that I could get rid of my sore feet, my neuropathy, and my swelling, and luckily I found out about nano socks. I'm so happy because they have honestly been the answer that I was looking for. Not only are they comfortable, but they're really easy to wear as well. Nano socks are made with 7-zone compression technology, which is just a fancy way of saying that they contour to your feet and they fit you perfectly. I love that they are such high quality because I know that I'll be able to wear them over and over again. They're built well and they really are made to last. These nano socks are perfect for if you're traveling or if you work on your feet all day. Right now, they are actually on sale for, get this, 50% off, so I snagged a few because it's honestly such a great deal. Do yourself a favor and go grab some for yourself today. Trust me, you'll be so happy you did.
less.
I'm a doctor, and my passion is to alleviate arthritis pain using nothing but natural methods. Can you guess the top?
To all of them who participate and those of them who have to replay it afterwards. Forgive our sins. In Jesus' name we pray. Amen. All right, guys, welcome, and thank you once again for joining us. Shocking the statistics I want to share with you from 2024. According to the State Board of Nursing, they said that the numbers are actually dropped, and this was actually the lowest in basic care and comfort. As you all know, the percentage usually tested from 6 to 12%. That's according to the blueprint, 6 to 12%. That's how many questions, the percentage of questions usually they ask on the exam. And according to statistics from the last 2 years, the number has dropped from, actually statistics shows will reveal that there were from 28 to 33% people who did not pass basic care comfort. De 28 à 33% pourcentage moun pa passé. Et nous dit numéro ça aussi capable grandir parce que of course en pile monde yo pas mette en phase sur basic care and comfort. Yo pense son bagay qui facile, vital signs, you know what's important about the vital signs. What do I need to know? Well, basic care and comfort, it's not just about vital signs. It's more than that. And I swear, I may have to do another live if I don't have enough time. I may have to do another live just to come back and finish it. Now, when we're talking about basic care comfort, guys, we're talking about assistive devices, and we're talking about elimination, bowel, and urinary. We're talking about mobility, and mobility. We're talking about nutritional and oral hydration. We're talking about personal hygiene. Basic care comfort is also rest and sleep. Also, religious and cultural postmortem rituals, the postmortem care, right? And the last thing is really end of life. And end of life, you all know we're talking about palliative care versus hospice. So tonight we're gonna break everything down. Along with that, nous parlons about questions pour capable reinforce those concepts. So when you go next time for NCLEX, so any basic nursing questions related to basic care and comfort, we don't want you to miss. Professor Leon wants to make sure you are comfortable. And just so you know, every week we will be bringing more topics. Like last week, we spoke about mechanical ventilation and chest tubes. This week, we're focusing on basic care and comfort. And after we finish basic care and comfort, the next target is cardiac. Yes, cardiac. And we're gonna break it down. So we just wanna make sure you are comfortable with basic care and comfort. So now let's first talk about assistive devices. Assistive devices, a lot of us, I'm sure a lot of you are comfortable, know how to use them. Let's say, what is the goal, if I were to ask you, the goal of assistive devices? Assistive devices. Cela signifie patient besoin li. Why? Because maybe after surgery, your surgery, they depend on it. And we're talking about whether if they need a cane, whether they need a walker or crutches or whatever assistive device that they need. That's what they need to learn how to use it. So the goal is really safety. That's the bottom line. Matter of fact, it's not just an assistive device. Any questions on NCLEX, it's always focused on safety. Yeah, safety is always the bottom line. So j'aime te dire ça from day one. What we're talking about, safety in communicating. That's what we call it, therapeutic communication. Safety in documenting, safety in medicating, safety in care planning for your patient. It's always about safety. All right, guys? Okay, so now let's quickly review. And I'm not gonna go into detail. I just want to make sure you guys understand the basic concept. Okay, so now we said the goal is to promote safety and independence, right? And the expectation is to make sure the patient can use those devices proper, effectively, and safely, right? Because we also want to promote independence. So now let's talk about cane. You all know, let's say if I have a left leg knee replacement or left knee injury or left hip injury. So you know the cane always goes where? Come on, guys, just start putting your answers because I know you know these answers. Come on, put those answers. The can must be placed always. Kote supposed mete can now. On the strong side or on the weaker side, guys? My friends on TikTok, put your answers. Facebook, YouTube, put your answers. On the stronger side, we place our cane. So now, okay, so now, but how do I move forward? Let's say now, how do we teach patients to move forward, to walk? So we already know the cane is already on their strong side. So when they are taking their first step, what goes first? So the first step, they're going to use their weaker leg with the cane. That is the first step. And now, before they even make that first step, what do we want to make sure? They stand up straight. And then the cane is where? Make sure it's at their what? Their hip level, right? And the angle flexion, that's what I'm showing you right now. That is kind of very high, but it should be about 30-degree angle flexion, okay? And the cane should be also 6 feet away from, okay, not 6 feet, 6 inches away, okay?
Watch what bread does to your diet goals.
They're lying to you about whole wheat bread. It's not healthy. It's packed with gluten and phytic acid, both dangerous anti-nutrients. Bell peppers, they belong to the nightshade family. Bad news, stay away. Ketchup, it's not a condiment, it's a sugar grenade. Plus, it's pumped full of preservatives your gut bacteria hate.
But real talk, what actually happens when I eat this?
Here's the short version. Your gut lining can start to weaken. Tight junctions can start to loosen. And suddenly, unwanted particles might be contaminating your bloodstream.
And this is why I get fatigued during the day?
Yes, but not only. Bloating, skin breakouts, stubborn weight that won't budge, it's all been linked to a weak gut lining. Heartburn is actually caused not by stomach acid. There has to be a certain amount of acid in your
from the side, okay? It's a 30-degree angle flexion, 6 inches away. And also, what else? So we said first step, together, weaker leg. Then the second step, now we go what? It's a stronger leg. That's the cane, right? So first step together and weaker leg, and second step and stronger leg. What about the walker? Walker, if we were to teach somebody how to use a walker, what do you do first? We said we're gonna push or lift the walker forward. Then second step, okay, it's what the first step patient's gonna take is what? With the weaker leg. And then the third step with the stronger leg, right? So that is the walker. Again, we want to make sure patient is doing what? The walker is placed at their hip level. We have to adjust and make sure it's safe and make sure we use what? How many degree flexion angle? 30 degree again. And going upstairs, if patient were to go upstairs, same thing, ou bien avec cane, ou bien avec walker, you're supposed to ça. You always know the stronger leg goes first, then the weaker leg, then the walker, okay? Then if they were to go down, same thing. Which one goes down? The weaker leg goes down first, and then what? The stronger leg, then the walker. Same thing with the cane. What about 2-point gait, 3-point gait, and 4-point gait? When we're talking about crutches, that's very basic, because with the crutches is what? You want to move with weaker leg and opposite crutch. That's what we call 2-point gait. And then what? The 3-point gait. I don't know if you guys can see my screen. I'm going to share my screen with you in a little bit. And then the 3-point is both crutches, weaker leg and stronger leg. And then 4-point gait is crutch, weaker leg, then crutch, opposite crutch, then stronger leg. So it's one at a time. That's what we call it, 4-point gait. Okay. All right. So now we are done with assistive device. Don't forget your hearing aids, very important. If you were to talk to somebody who has hearing impaired, it's important as a nurse that you have to stay on the side where they can hear you. Make sure that they wear their hearing aids. Make sure that they could see you if they are visual impaired. And make sure that they can see you, they could hear you. Always stay on their stronger side. Okay, so you can actually reach out to them and they can, and it's the same thing. If somebody is deaf, of course, you're not gonna yell at them. Make sure you stay at the eye level. If like they're sitting, ou même ou pas qu'à camper, you have to be at their level and make sure what? Make sure you do it. Make sure that they could see you and hear you. Or sometimes it's best what? You use what? A board, okay? All right, so now, elimination for bowels elimination. Let me see if I could quickly show you my screen. I want to show them my screen. Let me see. Yes, here we go. So you already see. So we just saw elimination. Now for bowels, let's say for urine, a lot of times if somebody needs a catheter, who needs a catheter versus Purewick? Okay, sometimes we think, oh, if patient cannot urinate, nobody on catheter or nobody on Purewick. But who needs that? Well, Purewick is for people who have incontinencies. Okay, they have incontinence. Your pipi, but pipi you pa kembe tolerate. But those who need the catheter, these are those who have urinary retention. So that's the difference. Okay, as basic as the concept is, but some people miss that. And for bowels, we understand. We always want to make sure we ask how many times, you know, did they have their bowels like 3 days ago. Why? Because if they have not had their bowel movement 3 days, we have to place them on a bowel protocol. That's usually most facility, that's their protocol. So that we would have to have what? A consult for registered dietitian or dietitian, whatever you have in your facility, so that patient can have what? So patient can make sure patient can be placed on a high fiber diet so that they can be able to pass their bowels, and make sure ambulation is like always the best thing. So we will be promoting toilet training, maintain fluid fiber, assess also for UTI, constipation, urinary retention, very, very important. Okay, guys? Okay, so now the next thing we have here, nutrition and oral hydration. So the key for that is to maintain, check for skin turgor. You guys know how to check for skin turgor, whether they dehydrated, check their ionos, their weight, and also check for signs of low albumin. Who can tell me signs of low albumin, guys? If somebody has low albumin, okay, what does that mean? What will be some signs and symptoms you will see on that patient? Of course, swelling, muscle weakness, fatigue.
Nobody's talking about moringa, and honestly, that makes me angry. You walk past it in the market, you hear the name here and there, but nobody tells you what moringa actually is. And honestly, that's the part that frustrates me. Because this one plant has 23 times the iron of spinach, 7 times the calcium of milk, 11 times the vitamin A of carrots, 10 times the vitamin C of oranges, 15 times the potassium of bananas, 4 times the fiber of oats. And somehow, you never hear about it. Meanwhile, people are spending hundreds on supplements that don't even come close. Moringa contains 92 of the 102 nutrients your body uses in one simple leaf. But the truth is, this isn't the only ingredient nobody explains properly. There are dozens of everyday herbs and foods with incredible...
Example, people who have low albumin, these are people who have what? Liver problem, kidney disorder, malnutrition. Please share the live, guys. Partage, because a lot of people think, oh, it's a basic care comfort. It's not important, but I just told you how many people who just fell from 28 to 33% from last year to this year. So the number, they said this is the lowest because people don't pay much attention to basic care comfort. Okay. And then what else? So electrolytes. Make sure that, especially like people who have NG tubes, this is one of the risks usually they have. So the longer they have the NG tube in, because of course we know the goal for NG tube is what? Stomach decompression, but that they're also at more risk of losing more electrolytes. So make sure if they need assistant for feeding, the position is very important. Make sure you make the food so appealing to the patient. Remember, the food must be colorful. You can't just choose a protein and carbs. Make sure they have vegetables. Make sure it's really based on their diet, but make sure the food is ready to go, appealing. You can't put a catheter on the table, or anything, let's say a urinary catheter ou bien un bagay qui pas attirant. Make sure they brush their teeth or wash their hands, and make sure they're happy and sit them properly. Okay. Now let's go to personal hygiene. This is another basic care comfort. Personal hygiene, we said the goal is to promote what? Dignity, comfort, and prevent infection. So what is our goal? Our goal is to, let's say if you were to have a dementia patient, for instance, how would you encourage your dementia patient to bathe? And you see that she just had a bowel movement. She just had a number 2 and she is soiled. She needs to be clean. But how would you talk to her versus a schizophrenic patient? You cannot approach them, guys, the same way. And that's how NCLEX want to make sure the therapeutic communication, because I don't know if somebody has an idea, a suggestions. Let's say you have dementia, or how would you approach that person? How would you encourage her to take part or to clean herself, or even take a shower or a bath? How would you talk to her? Maybe encourage her to participate, right? Or Mrs. Johnson, could you help me? Here's the towel. Can you go ahead and help me turn on the water? You know what? We want to get you ready, cleaned up. However, I need your help. Can you? This is to help you. Can you help me? Can you just get the water, and then can you choose your clothes, what you're gonna wear? You know, get her involved as much as possible. That is usually how you get them involved, because remember, they're not really aware of facility. You don't always present reality to them. You kind of distract them and get them involved anyways. That's how you get them. Of course, you're not lying to them, but you're distracting. That's different. Okay. Whereas if you were to present for a schizophrenia patient, these people, you have to be careful. You have to present reality to them. Okay. All right. Mr. Johnson, I see that you have you kind of soil. It's time to it's your shower is due today. Give them choices. Are you ready now to take a shower? And if it says no, guys, by all means go back. Tell okay, or you have to go back, and then before you leave your patient, you probably want to ask them, so what time would you like me to come back? Maybe in 30 minutes or so, and tell them the reason why they need a shower. Present reality to them. Whereas your Alzheimer's patient, you distract them. But your schizophrenic patient, you need to be careful and also be firm and present reality always to them. All right, in a safe manner. All right, the next thing, guys, the next basic care comfort here is rest and sleep. So the goal, we said, is to manage sleep disorders, and especially if they take naps. during daytime, of course, they're not gonna be able to sleep. They're not gonna be able to sleep. So make sure they don't take naps during daytime. So when it comes to nighttime, sleep time, so they can sleep, and make sure they could get a nice bath or maybe like a warm milk or something to promote good sleep. Okay, and make sure they are ready for it. Okay, now of course your diabetic patient, you know, especially if you know they're gonna go low on their blood sugar or high on their blood sugar. We will be talking about those, Somoji effect, right? All of these. So you need to make sure you have to know, when we're talking about diabetes, you have to know before bedtime, what do you give them? Okay, so we will talk about that when we get to diabetes session. But now we are talking about comfort and basic care and comfort. So rest and sleep, we said providing a quiet environment. Make sure they could see if they were to get up and go use the bathroom. Make sure there's enough lighting, and limit the amount of caffeine intake, because that's like, they're not gonna fall asleep. Even chocolate is a type of it's stimulating. So make sure that you don't give that to them before you sleep. An example, let's say if someone is taking diuretics, Lasix, or a loop diuretic or diuretics or whatever type of diuretics, you want to make sure they don't take it at night. The best time to take those diuretics is when, guys? Daytime, right? Yes, so they could be able to go to sleep quietly, okay? And their sleep don't get distracted, okay? And always assess for pain. So nothing that's going to distract the sleep. You want to make sure you are addressing that perfectly, okay? All right, so now we're going to talk about, let me see. We're gonna go to religious, cultural, and postmortem rituals. Okay, let me see if I could show you that. Let me see, right here. Can you guys see my screen? Pastor, if you can help me, because they're not able to see that. I wanted them to see the religious section, which is here, because I wasn't able to drag it on my screen, but now I can see it, but I don't know how we'll be able to show it to them right here, like this part right here, if we can. So I'm gonna share my screen with you in a little bit, guys. Just be patient. Yeah, it went blank. Just be patient with me, guys. Thank you. I don't see the people. But I know you're here, and welcome. Please share the live. And I know it's basic care comfort. You guys think, well, I know these things already, but I just told you a lot of people fail their NCLEX because of basic care comfort, because they think that these questions are too easy. And that's what happened. And that's why I want to make sure you guys don't fall into, no, that's not it. Yeah, please. Yes. Go right here. Hold on a second, guys. Right here. Yeah, it's not showing. Hold on a second, guys. We're working on it. It's like basic care comfort here. Yes. Yeah, but it's not going all the way down. You see, it stopped showing. There you go. Now it is. Okay. Now
start doing this with your dog. This 2-minute dog food trick is helping dogs live fuller, happier lives.
This is my wife, Katherine Heigl. Dogs love her, like a lot. And she loves them so much, she spent years researching which human foods are amazing for dogs and which ones secretly do more harm than good. She read every label, every study, talked to every canine.
Now it's actually showing. I see the rest. Okay, guys, I see the rest. No, it's not. It's not been showing. Okay, I don't know what happened. So it's actually here, but I wanted to make sure you guys see. But anyways, I guess I could just show it with you guys, show it to you. So we said rest and sleep. The goal is to promote healing. The key is what? Quiet room, manage pain, and then we're gonna talk about end life. We're probably gonna touch that next year because it is a whole chapter all by itself. But now I wanted to talk to you guys about the religious and cultural, okay, on postmortem rituals. Let's say someone has a death in the family. So how would you go about knowing what religions, what practices what rituals you need to know for each? If you could help me, because whatever is showing is not, I can't. If you can hold on, guys, I need to be able to show the screen because whatever is showing is wrong. And it keeps showing here. I don't know. Hold on, guys. Having a little trouble sharing. Just be patient. Okay, while we wait, the first religion is the Muslim. So first of all, Muslim, their beliefs. They believe that the body should be treated with dignity, modesty, and cleanliness. Okay, that's the Muslim. So, and of course, you guys know this question always come on NCLEX. There you go. Thank you so much. Where the body, don't do that. It's actually showing. So don't stop sharing. Okay. So the body, we said the face should turn toward Mecca, which is southeast in the US. So anywhere you are in the United States. So that's what the body should face toward Mecca. And this actually comes on NCLEX. What about, especially the head of the bed, okay? Toward like the window. But it really depends where the bed is located, right? And only the same gender caregiver should handle the body. So that's for Muslim. And washing, let's say, is performed by family Muslim community members. So washing the body is really, so you need to know their beliefs. Muslim, they're very particular. And also autopsy is generally forbidden. Okay, unless legally required. So you can't faire autopsy. Okay, you can't faire autopsy. What about burial? Burial occurs as soon as possible after death, and often 24 hours. Okay, so then your nursing actions is to make sure you notify the family ASAP. If you have a Muslim family who's actually deceased, make sure you notify the family ASAP. And keep the body covered, especially the genitalia, and do not remove religious amulets or garments. Okay, so make sure. So if you see the word hijab, that's the name. Okay, so that's Muslim. The next one, we said make sure allow the family to wash the body, to prepare the body, and do not embalm unless required by law. So we don't usually do that at the hospital anyways. What about the Jewish? Their beliefs. We said for Jewish, the dying person should not be left alone ever. Presence of loved ones is very important. So if you don't, let's say if you know that they're not gonna be present, so you have to make sure if you have a Jewish family who's dying, make sure you call the family ahead of time so they could be present and make sure that they come, or else you cannot even leave the room. You have to be in the room, okay? Because it's, or make sure there's somebody there. It says dying person should not be left alone. Postmortem care is performed by Shivra Kadisha. That's what you call a Jewish burial society. Now for autopsy and embalming are discouraged. So they don't encourage that. So this is a second religion who don't believe in autopsy and embalming. Okay, so autopsies, so we just saw Muslim, they don't do that. And then Jewish community, Jewish religion. And that's considered desecration, just so you know. What about body? Body is not touched or washed by non-Jews if avoidable, okay? What about burial? Burial should occur as soon as possible, often within the first 24 hours. These are very important concepts, for basic care comfort when it comes to death and dying. Now, nursing actions: cover mirrors in the room. Okay, that's mourning rituals. Avoid unnecessary touching of the body. Okay, if you don't have to, don't do it. Okay, let the family member take care of that. Place a sheet over the body. Do not remove religious items. Contact a rabbi for specific guidance, and do not remove tubes or IVs if autopsy is not required, because they're not gonna do autopsy anyways. Like this week, I had a student of mine. She said, yeah, that is so true. I work on the floor and we usually do postmortem care. And for Jewish patients, we never remove any tubes because they believe that everything that comes with the body must be carried out, must be taken as a whole. So no pa ka retire anyen, même IV line or catheter or NG tubes, whatever tubes they have, or PICC lines must be stayed together. Parce que yo pa pral fè autopsy, but they pa vle retire tube yo. So you have to remember that. What about Christianity? Christianity, usually most people don't have trouble with that because we have a lot of people that are Christian. So their belief is what? Practices vary. Most accept organ donation. They also do autopsy. They allow, okay? And they allow autopsy. Prayer must be said at the bedside, okay? Especially for Catholics, the last rite must be done. So make sure if you have a Christian Catholic patient, if they need to call, you have to let the family aware patient's gonna die, or if they want to call on the chaplain, or so they could get their last rites done. Okay. And some prefer burial, others cremation. And nursing action, your responsibility is offer the call a priest or a pastor or chaplain, and respect preferences for last rites. That's before their die. Okay, before their death. And allow family to remain and pray. And it really doesn't matter background of the patient, as long they want to stay and with their loved ones, even after death, they want to start grieving, mourning, let them stay in the room. Don't rush them to take the body to the morgue. Don't do that. Prepare the body before you let them know. And then, like you said, you're not going to be touching the body. Depends on what religion the patient is. Si patient sont Muslim, so patient sont Jewish religious background. So ou pa ka juste à laver, al fait postmortem care. You have to get that permission from the family. You guys get that? Perfect. Now, what about the Hindu religion? Their beliefs is that the soul is eternal, death is a transition, and body is bathed by the family, and a sacred thread, that's what you call a puja, may be placed. Cremation is preferred. That's for Hindu now. Okay, not for Muslim, not for Jewish, but for Hindu, yes. They do cremation, and also autopsy is discouraged. So just like Jewish, just like Muslim, they don't encourage autopsy, but they do prefer cremation. You see the difference? Okay, now nursing action for Hindu patients: do not.
Is your mind secretly sabotaging your success? What if there was a way you could instantly stop self-sabotage and reprogram it for success today? And sleep all the way down, all the way down. The world's highest achievers have a secret that they don't advertise. It's not their morning routine, it's not their diet, it's how they've programmed their subconscious mind for massive success. Don the Hypnotist here. You may have heard about me on the Joe Rogan podcast or ESPN. Maybe your favorite NFL, UFC, Olympic athlete, actor, or celebrity had done some work with me. I worked with this guy named Don.
Remove sacred threads or jewelry. Very important, guys, to remember. Allow family to perform rituals and keep body covered and handled gently. Okay, respect with dignity. Very important. And you guys know, as nurses, it's okay to show you care. If you want to cry, it's okay. You don't have to hide your feelings. Show empathy. Show the patient that you are human. If you want to cry, especially it was a patient that you are so dear to. So it's okay to do that. But also remember your attentive listening. That's what they mostly need. So don't talk. Be quiet. Listen. There is sometimes that you need to be quiet and just listening. And that's the time. Unless they ask you questions, you only answer specifically to the questions, but you don't offer suggestions. You don't talk so much that you don't need to. Very important, guys. Attentive listening, because remember, there's mourning, the grieving. Now, what about the Buddhists? The Buddhism, their belief, death is a spiritual moment. Chanting may occur at the bedside. So, si vous vivez dans chambre nan, autant de moun nan se Bouddha ou commence à chanter. That's their culture, guys. The body should remain undisturbed for several hours after death to allow for spiritual transition. Okay, that's their belief. And nursing action now provide a quiet environment for rituals. Avoid touching the unnecessary after death and allow monks or spiritual leaders to perform rites. That's the Buddhism. Okay, the next one. Now, I do have questions for you guys. Are you guys ready? Are you guys ready for the questions? Okay. Well, I hope you guys are ready to answer, because I'm going to start the questions here. And after we're done, we also have one more session for palliative care and hospice. So it looks like I may have to do that next week. I'm going to see how much involvement we have. I don't see anybody from TikTok, anybody from YouTube. I don't see, but let's go with our first questions. But first, let me check. Could you please check for me the TikTok account right here to see how many people, because I'm going to start with the questions just to make sure I give credit to, the credit is due to, and if somebody answer, I don't want to miss them out. I don't want to miss on that. Okay, so let's go, guys. Postmortem cultural competency. First question. A nurse is caring for a deceased Muslim client. The family requests to perform rituals, washing of the body. Which action by the nurse is most appropriate? Okay, guys. I don't see my TikTok people. Answer, please. Come on. Share the live. A nurse is caring for a deceased Muslim client. The family requests to perform rituals, washing of the body. Which action by the nurse is most appropriate? A, decline the request due to hospital infection control. B, prepare the body by removing all medical equipments. And C, allow the family to wash the body with guidance, maintaining dignity. And let me hide this so I could see. Notify security to limit family contact with the deceased. What is the answer? Answer, guys. I'm ready. I'm waiting for your answers. You guys could put your answers. I'm not able to see your answers. I don't know if you could bring the screen down for me so I could see their answers. I'm not able to see their answers. But anyways, let's go. The answer, we said the nurse is caring for a deceased Muslim. Remember, Muslim family requests to perform rituals, washing of the body. Which action by the nurse is most appropriate? A, decline the request due to hospital infection control policy. B, prepare the body by removing all medical equipments. C, allow the family to wash the body with guidance, maintaining dignity, and notify security to limit family contact with the disease. We just learned about religious rituals, about Muslims. So the answer is C. C is correct, guys. Those of you guys who answer C, you are correct. This is the rationale for C. Islamic beliefs emphasize rituals, washing by the same gender, family, or religious leaders. Supporting this request respect cultural values and promotes dignity right? That's what we're supposed to do. But A, D are cultural and sensitive, and B may interfere with autopsy needs or violate policy. So you guys get that, right? That was an easy one. Okay, the second question now. Get ready, guys. Okay. All right. And okay, the family of a terminal ill client becomes angry and says, "You're just letting our loved one die." What is the nurse's best response? Remember, people, they go crazy when they see death is imminent, when they see their loved one is dying. Sometimes they make you responsible. They curse, they yell, they go crazy because they just can't believe it's happening. Remember the stages of death: shock and disbelief, bargaining, accepting, so like denial. So all of these things are come up in their mind, shock and disbelief, and they're going crazy. So now they are telling you, the family of a terminal ill client becomes angry and says, "You're just letting our loved one die." What is the nurse's best response? A, we're doing everything possible to save them, especially if they see you performing a cold blue on that patient, chest compression, CPR. That's why sometimes it's best to get them out of the way, okay? B, I understand this is difficult. Can you share what concerns you the most? C, there is nothing else that can be done now. D, your loved one would want to be at peace. So what is the best answer, guys? Come on, put your answers on YouTube, your TikTok. I understand. I guess I understand this week. I kind of started early. I usually start at 8 p.m. So people expect to join me at 8 p.m. But today I have church service. The next 4 weeks, instead of starting 8 p.m., I'm going to start at 5:30. Okay, guys? And that's the best I can do. So after 4 weeks, I'm going to go back to 8 p.m. so we have more time, because some people may be still at work. And just so you know, that's why I changed the schedule. And that's why I don't see so many people today. But that's why, guys, I have a crusade in my church, and the next 4 weeks, I won't be available at 8 p.m.
Should these glasses be illegal in the US? Nobody believed me at first, but now everybody wants a pair. My friends roasted me for buying miracle glasses online. They said I got scammed, but then I showed them what they could do. Now they're all begging me to send them the link. They're called Clarity Blue glasses, and they're nothing like the glasses you're used to. These things actually adjust automatically to your eyes, whether you're reading a book or looking across a room. Seriously, they correct both farsightedness and nearsightedness without needing a prescription. It's like getting perfect vision on demand. And the best part? No doctor visits, no eye tests, no lens swaps. Let me give you 7 reasons why Clarity Blue glasses are blowing up right now. 1. They automatically adjust to your vision. From 100 to 700 diopters, they adapt instantly as you go about your day. Just put them on and everything gets clear. 2. They protect your eyes from harmful blue light and UV rays. Whether you're glued to a screen or out in the sun, your eyes are covered. No more digital eye strain or squinting in bright light. 3. They're insanely lightweight. You'll forget you're even wearing them. At just 1.5 grams, there's no nose pinching or ear pressure, just all-day comfort. 4. They're impact-resistant and durable. You can drop them, bend them, toss them in your bag. They're built to last, not some flimsy drugstore pair. 5. They work for literally anything. Reading, driving, computer work, watching TV. One pair does it all. No more switching between readers and distance glasses. 6. Clarity Blue glasses are perfect for any age. Anyone tired of updating prescriptions or juggling frames, they just work. 7. No subscriptions, no hidden costs. One-time purchase. That's it. No blue light glasses that need replacing every 6 months. These are built to stay. And here's the kicker. They're already banned from Amazon, Walmart, and Home Depot for being too powerful. Right now, Clarity Blue glasses are offering 50% off and a 30-day money-back guarantee. But this deal won't last long. Once they're sold out, they're gone. So if you're tired of blurry vision, eye strain, and expensive optometrist visits, click below, grab your Clarity Blue glasses, and start seeing clearly today, before your friends start begging for the link too.
Okay, what's the answer? The answer, but you could always go back and watch the live afterwards. The family of a terminally ill client becomes angry and says, you're just letting a loved one die, what is your nurse best response? A, we're doing everything possible to save them. B, I understand this is difficult. Can you share what concerns you the most? C, there is nothing else that can be done. D, your loved one would want to be at peace. The answer is B, as in boy. That's what makes sense. Okay? Uses therapeutic communication to explore the family fears and grief. Because remember, they have anger, they have frustrations, they are shocked and disbelief. So they have to express themselves. So you need to be able, don't take it personal. Don't think they're biting you. Don't think they have beef with you and you start biting back and talk nasty to your patient. No, you need to give them freedom, a way to express their anxiety, their fear, their frustrations. Okay, so that's why B is the answer. A is misleading in palliative care, and C, D, their emotional state. You guys get it? Okay, now the next question. A nurse is caring for a bedridden client. Which intervention is the most effective for preventing pressure injuries? A, massaging bony prominences every 4 hours. B, repositioning the client every 2 hours. C, encouraging fluid intake. D, keeping the head of the bed elevated at 60 degrees continuously. The nurse is caring for a bedridden client. Which intervention is the most effective for preventing pressure injuries? A, what do we have? A, massaging bony prominences every 4 hours. Repositioning the client every 2 hours. C, encouraging fluid intake. And D, keeping the head of the bed at 60 degrees continuously. So what is the most effective way of preventing pressure ulcers, guys? What are your thoughts? What are your answers? We don't massage. Yes, B, repositioning. These are basic care comfort questions, but I'm telling you, most people miss those. So C is helpful hydration, but not primary prevention. And D, increases friction. Okay. Okay, the next question. The nurse is feeding a client recovering from a stroke with impaired swallowing. Which action is a priority? A, encourage fluids to help swallow pills. B, place client in high Fowler position during feeding. C, serve thin liquids with each bite. D, administer all medication before feeding. The nurse is feeding a client recovering from a stroke, impaired swallowing. First of all, NCLEX have a question. Who would be the appropriate staff to feed that client? Would it be the LPN, the RN, the speech therapist, or the CNA? If someone has a history of stroke or have difficulty swallowing, which is dysphagia, impaired swallowing, which staff member would be appropriate, guys, to feed that client? RN or PN or CNA? It's the RN, guys. The RN, yes, because, and even if you were to go to a restorative dining room, the RN would have to be the one in there and make sure the TV are off, provide a very serene, calm environment for them, turn off the TV and all of that, so they don't, aspirate on their food. Okay, so what's the answer, guys? If I have impaired swallowing from a stroke, which action is a priority? Encourage fluids to help swallow pills, place client high Fowler during feeding, serve liquids with each bite, or administer all medications before feeding? The answer is yes, B as in boy. High Fowler positions, well, that will minimize aspiration risk. And that's the first thing you want to make sure you do. The next question, guys. A hospitalized client reports poor sleep. Which intervention is most appropriate to improve sleep quality? Remember, I told you sleep and rest is part of our basic care comfort. So how would you encourage the sleep to make it better for them. Sleep quality. A, administer sedative medication at bedtime. B, encourage long daytime naps to reduce fatigue. C, cluster care activities during the night shift. And D, coffee with dinner to increase appetite. What is your answer? C is the answer. You're all correct. Okay. C, cluster care activities during.
You don't need a second job. You just need to know these AI tools.
So this is how I became the most dangerous person in the room. One habit changed everything. I replaced social media with micro-learning. Now, instead of wasting time on social media, I spend 15 minutes a day actually learning how to use AI for writing, planning, brainstorming, the real work. That's it, just one skill a day. This is the 28-day AI challenge built for beginners over 40. Starts tomorrow. Tap the screen to join us and try the one habit that really makes you unstoppable.
The night shift. That will clustering care minimize sleep disruption. Okay, just so you know. A and B, we said A may be overused and not first line. B, disrupt circadian rhythm. That's why you would not encourage long day nap. That was said that was not appropriate. And coffee, these have what? They're stimulating. Okay, include caffeine, which worsens sleep. So even chocolate is not good drinks to give patient before sleep, right? Okay, 6. Let's go. A client with urinary retention has an indwelling catheter. Which finding should prompt immediate intervention? A client with urinary retention has an indwelling catheter. Which finding should prompt immediate intervention? Remember, I told you urinary catheter is for people who have urinary retention, and PureWick or condom catheter or other urinary device, that's for people who have what? Urinary incontinences. So now A, 40 ml urinary output. B, urine appears amber in color. C, client reports suprapubic pain. D, urine bag is placed below the bladder level. So client with urinary retention has an indwelling catheter. Which finding should prompt immediate intervention? 40 ml urine per hour, urine output. B, urine appears amber in color. 4, urine reports suprapubic pain. And D, urine bag is placed below the bladder. What's your answer, guys? Easy peasy. C is the answer. Client reports suprapubic pain. That is something should prompt immediate intervention. Why? Suprapubic pain may indicate blockage or infection. So that's why you want to make sure you make that your priority. 40 ml is a normal urine output. Remember, it's 30 ml above per hour. So 40 ml is perfect. And B is a typical finding. Urine appears amber in color. Yeah, that's a typical finding. And D, urinary bag is placed below the bladder. That's to promote drainage. That's the correct placement. Okay. Next one, 7. We got 3 more questions after that. Now, a terminally ill client rates pain as 8 out of 10, but is concerned about opioids addiction. What is the nurse's best response? The pain is what? 8 out of 10. And client is concerned about opioid addiction. What is the nurse's best response? A, we can try meditation instead. B, opioids are not appropriate and effective in end-life care. C, you should avoid strong medication if possible. And D, addiction is likely at high doses. Okay? So, qui sobra le fait? What do you do? What's the answer? What is the answer, guys? terminally ill patient, pain, 8 out of 10. But is concerned about opioids addiction. What is a nurse best response? Mon TikTok moi yo, m'ka comprendre parce que jodi a m'pa commencer le noter expect moi, but you guys will be able to see the live afterwards. Okay. So the answer, we can try meditation instead. Is that what the answer is? B, opioids are appropriate for effective life care. C, you should avoid strong medication if possible. D, addiction is likely at high doses. The answer is B. B as in boy. Opioids are appropriate and effective in end of life care. Remember, morphine, that's opioids, right? So the goal is, it says in palliative care, the goal is comfort, right? And opioid use is appropriate. And A may be used adjunctively, right? Okay, we can try medication instead. Meditation that they also use, but the pain is so bad. Douleur accidentatoires, they have to use opioids. That's what gives them comfort. And we already know the side effects, and we have to present the side effects to our patient. The respiratory depression. What else, guys? Constipation. What else? It drops the blood pressure, the respiration. They need to know, okay? All right, number 8. We got 2 more questions after that, and then we'll be done for the live. And then next week, we'll continue with palliative and autopsy, palliative and hospice. And then just to finish that section. Remember, I told you guys, basic care comfort is very long, but I just want to make sure you guys are comfortable with any of those questions, okay? Like I told you, the statistics for the past 2 years was 28 to 33% people are not passing. And they said that's very, very high, okay? So they want to make sure people are more comfortable with their basic care comfort skills. Okay. A client is scheduled for an autopsy after sudden death. Which action by the nurse is correct? A, remove all invasive devices. B, perform a complete bed bath. C, leave IV lines and catheter intact. And D, shave body hair and dress wounds. A client is scheduled for an autopsy and sudden death. Which action by the nurse is correct? A, remove all invasive devices. B, perform complete bed bath. C, leave IV lines and catheters intact. And D, shave body hair and dress wounds. So you see in this question, it doesn't mention what the religious background of the patient. Of course, if they were very specific, they tell you whether it's a Jewish or Muslim, we know they don't want any of those tubes to be out. They got to go with them, and they don't do autopsy. But they don't talk about the religious background here. They just say a client is scheduled for an autopsy. So obviously that patient is not Jewish. Neither of this patient is Muslim because they want autopsy. Do you guys get it? So which action by the nurse is correct? Do you remove all invasive devices? Do you perform a complete bed bath? Do you leave IV lines and catheters intact? Or do you shave body hair and dress wounds? The answer is C. C as in cat. Yes, you leave IV lines and catheters intact, because autopsy requires preservation of the body and devices for forensic analysis. That's why, guys, forensic analysis, that's the purpose. They want these tubes to stay in. Until they're done, they will let the funeral homes what to do next. But they want to make sure you don't have those out, okay? And make sure patient have their tags. They will tell you. Remember, they need their 2 tags, 1 foot, 1 in the hand. So make sure when they come to pick up the body. And next week, we're going to talk about that, palliative and hospice, okay? And we'll also do some more questions on basic care and comfort, okay? So now the next question, we said, question 8, autopsy require preservation of the body devices for forensic analysis. A and D violate protocol, right? And B is not performed prior to autopsy. Does that make sense? Okay. Now, question 9. A client is learning to use cane. There you go, assisted device. Which instruction by the nurse is correct? A, hold the cane on your weak side. B, move the cane and strong leg together. C, advance the cane 18 inches ahead. And D, lean heavily on the cane when walking. What is the proper answer? Is it hold the cane on the weaker side? B, move the cane and strong leg together. C, advance the cane 18 inches ahead, or lean heavily on the cane when walking. What's the answer? What's your answer, guys? Those of you who think it's very easy, basic care comfort, don't let basic care comfort fool you guys on NCLEX, okay? The answer is B, move the cane and stronger leg together, okay? It says here, the cane should be held on the strong side. It moves with the weaker leg to maintain balance, okay? Now, just so you know, you see, it says move the cane and stronger leg together, but it's really the cane should be held on the strong side and it moves with the weak leg to maintain balance. Okay, so the weaker leg moves with the cane, then the stronger legs follow. But of all the answers here, B makes more sense, but they really should have had weaker leg together with the cane. That's what it should have been, okay? Just so you know, guys, I don't want you to miss that. And 10, last and not least, as you could see, A, C, and D are incorrect. They are unsafe because we hold it on the right side, the strong side, advance 18 inches away, that's too far, and we don't lean heavily, okay? That's putting too much pressure. 10, question 10. Nutrition and cultural beliefs. A Hindu client refuses beef based on protein supplements. A Hindu client refuses beef-based protein supplement. What is the most appropriate nursing action? A, explain the nutritional value of the supplement. B, offer a plant-based alternative. C, notify the provider to enforce nutrition plan. And D, document the non-compliance in the chart. A Hindu client, remember we gone over Hindu clients, okay? They're very specific, what they eat and what they do, their beliefs. Remember, they believe soul is eternal, body, family, sacred. And we said cremation is also preferred. Autopsy is usually discouraged. And we said as nurses, we all will not remove any jewelries, any sacred threads. All family perform rituals and keep body covered and handle gently. That's your Hindu patients. Now it says they refuse beef based on protein supplements. What is the most appropriate nursing action? A, explain the nutritional value supplement of beef. B, offer a plant-based alternative. C, notify the provider to enforce nutrition plan. And last, document non-compliance in the chart. What do you guys think about that? What's the answer? The answer is B. You have to offer an alternative, right? They don't want to eat beef, protein. So then this is the rationale. Respecting dietary restrictions while offering alternative reflects cultural competence care. So you don't want to leave them hungry, so you have to provide alternative way. Okay? And A may be dismissive because you explain the nutritional value. That's not what they don't care about that. C and D, that's lack cultural sensitivity, like document the non-compliance. No, that's not what that is. And C, notify the provider. How is that going to help you or help the patient?
Ladies over 180 pounds, start your 7-minute indoor walking routine for cortisol detox. In 1 week, you'll feel better. In 2 weeks, you'll look better. In 4 weeks, your besties won't believe your results. Watch our transformation from size 20 to size 12 with indoor walking. This is what weight loss walking looks like home. Several months ago started this indoor walking challenge from Walk Fit. We walk for just 7 minutes daily. Our bodies home and our stamina improve. Calculate how long it takes to lose 42 helps with walking.
Okay, guys. So thank you so much. Now let me see how many of you were participating. Let me go back to this. Okay. Okay. But we are done. I hope you all were able to view the answers. Okay. And participating. But this settles our life for today. And then next week we will proceed again. We're starting earlier this week is because of a church meeting I had on Sundays, and that's gonna go for another 3 more weeks. Okay, after this week. So, but after that, we will resume our 8 p.m. schedule. Okay, because I understand some people at work, they're not able to come early, but you can always share the live and review it later. So I have 5 people, guys, who are waiting to start online class with me, whether they want online or live, I don't know, but I'm actually taking people anywhere out of states, anywhere in Florida. If you want to join my class, it's I have 5 people so far on the list, and I am actually waiting for 5 more. So I am challenging you guys. If you know a friend, if you have 5 more people, call me. My number is 201-889-8103. Let me put my number, 201-889-8103. My name is Mrs. Leon. And if I have 5 more people, I will start launching the class, and I'll tell you everything about the class. My class is usually 8 weeks, and I do offer a whole lot: binders, questions, books, and I also launched 2 books recently. I'm gonna share with you. Let me just grab them quickly before I leave. Last week I did not have volume 2. This week I do have volume 2, and I hope you can see. Let me see, you guys can see. Okay, so the first one is NCLEX Master Review Volume 1, and I also have Volume 2. Volume 1, guys, is really the blueprint of NCLEX. And I did explain what that is. When you go sit for your exam and they said, okay, here's the blueprint. This is how you did not pass. You didn't pass basic care comfort, which we did today. You didn't pass psychosocial. You did not pass managed care. You didn't pass pharmacology section. So I break down every section here of the blueprint, and I have examples along with questions. And toward the end, I have most missed questions on NCLEX, over 400 or 500 questions you'll see in this book. There's quite a bit, but I always tell my students, make sure you read every detail because it's quite detailed, because sometimes we miss questions. It's not because we don't understand, but we don't take time to read. And it's important that we read. So it's important that we do take our time and read those questions. Okay, guys? So just so you know, it's very important. All right? And then the second book is volume 2. It's case studies, the 10 types of NGN types. Okay, and I tagged them with case studies. So we're talking about the bow tie, the matrix, the drag and drop, the highlighting, the hot spot, you know, and you'll see a lot of questions and strategies and techniques also. So these are the 2 volumes I have so far. So if you're taking this class with me, you will also have access to these 2 books. All right. So just so you know, I have 5 people and I'm waiting for 5 more so I could get the class started. So please share the live, and I'm done. And I don't know if you guys have any questions for me. Anybody has any questions before I go? All right. All right. Okay. So let's have a word of prayer before we go. Father God, thank you so much for making this live possible again today. And we thank you for your presence in our midst. And please again be with those that are in nursing school, those who are getting ready for an exam this week, those who are on their journey to prepare for whether it's a PN exam or their RN exam, and they are working so much. Sometimes they don't even have time. Lord, I'm asking you to provide also financially for them so they could have time to study. Sometimes it's not even that they don't get the material, but it's because they don't have time to put or the effort to put into it. So I'm asking you for financial blessing on these individuals. Provide for them, for their family, their loved one. At this time, we also want to pray for those of them who have difficulty, loved ones, people that don't have a job. We're talking about the loved ones in our communities facing tragic moments right now. We ask you to have mercy. Mon Biden, yo Seigneur, gen pitié pour yo, ba yo en chance pour capable joindre papier pour travail. Sauvez-nous, Seigneur, donne-nous malades la santé, aux mendiants le pain qui pleure, à l'orphelin une demeure, aux prisonniers la liberté. Thank you so much, Father, for making this life possible. In Jesus' name we pray. Amen. Amen. Thank you so much, guys, for staying till the end with us. And we will see you next week and share the live. Thank you so much. And that's it. Bye-bye. God bless. Thank you. Let's end the live. Where do we go? End live. Hold on. And hold on.
I'm a doctor, and my passion is to alleviate arthritis pain using nothing but natural methods. Can you guess the top 3 foods that I would recommend you to eat? The first one is olive oil. It has a compound called oleocanthal, which has a similar effect to anti-inflammatory meds like ibuprofen, which helps keep your joints healthy, flexible, and pain-free. The second is blueberries. Blueberries are loaded with antioxidants, vitamins, and minerals, which are essential to help our body soothe joint pain. And the third one is pineapple. Just like olive oil, this juicy yellow fruit has significant anti-inflammatory effects. It's all thanks to the enzyme it contains called bromelain, which several studies show is effective as a treatment for joint pain and arthritis. However, if there's something I've realized after 20 years of treating people with joint pain, is that you need to stop damaging your joints before you can repair them. Otherwise, it's like trying to fill a leaky bucket. You can't put water in until you patch up the holes. And after working with thousands of patients and hundreds of hours of research, my realization is that if you want to stop damaging your joints, you have to stop eating 5 specific foods. 5 foods that can skyrocket your inflammation levels, make your joints burn, and take a massive toll on your body. That's why I've decided to create a free presentation with 4 other arthritis experts where we reveal the 5 worst foods for arthritis. And without realizing it, I bet you're eating at least 3 of them every single day. Not only that, but the number 1 worst food for arthritis is actually a health food. Can you believe that? If you want to find out what the 5 worst foods for arthritis are, simply click or tap the button on your screen. See, the more you eat these foods, the higher your inflammation levels will be, leading to rampant joint pain in your back, hands, shoulders, knees, and other parts of your body. And the worst part is, it's likely your doctor knows nothing about these foods. In fact, he probably thinks they're healthy. So if you're ready to get rid of the flare-ups and start waking up pain-free again, simply tap or click the button on your screen to discover the 5 worst foods for arthritis and joint pain. I guarantee number 3 will shock you. But don't procrastinate, as you won't be able to find this presentation anywhere on the internet. So the only chance you have to watch it is by clicking the button below now. Once this video ends, your opportunity to watch a presentation will be gone. Click or tap watch now and discover the 5 worst foods for arthritis. This is Dr. Paris, and I wish you the best.
Hello, everyone. Bonsoir à tous. Good evening, my friends. Good evening, my followers, and welcome back. Earlier, I had trouble with my computer. Lord knows what I need to go through, but I thank God for another day, another opportunity, and I hope you're doing well, even though you don't get a chance to join this live right now. But you can always watch it over and over again. And tonight we have a very important topic for you. It is the one that we want to share with you, the one that it's about heart failure, okay? Heart failure, the left versus right, left versus right. Again, this is Mrs. Leon. Please share the live. I don't see the title being shared on this the live, but really we're gonna share with you the right versus the left. So before we start, I would like to share some fun facts, very important fun facts about the heart. Okay, so first and foremost, let's have a word of prayer quickly. Father God, we thank you for giving us a new day, another opportunity to be alive. We ask you to please bless somebody who's struggling with nursing classes, especially their med-surg or critical care nursing, or who's studying to pass their NCLEX, Father. Please help them to be able to analyze and apply their knowledge and be able to pass their NCLEX when they go for their test. In Jesus' name we pray, amen. Okay, guys. All right. As I showed you earlier, right before I took off, I am presenting a topic on heart. Okay, this is one of my favorite topic. This is my model here, a heart. Hope you can see. Yay. All right. Okay, so you already know the heart has 2 systems in one. I call it two systems in one. What does that mean? It has a circulatory pump and the conduction system, okay, which allow the electricity. That's what causes the heart to beat. But the circulatory system, that's the pathway, the blood flow, all the 13 steps, right? From the A to Z. We're talking about, what is it? And superior vena cava, right? All the 9 yards. So you all know the heart has 4 chambers, 2 ventricles, right? Which is at the bottom, and then left and right. And then you have 2 atrium, right? They receive the blood and it passed through the valves, has 4 valves, right? And the valves, they actually prevent blood backup, okay? That's the goal of, let me remove this so you could see. That's the goal of the valves. It actually prevents backflow. You know, there's some problems that cause backflow. Okay, that means the valves are not working properly. Okay, so that's what happens. So now some fun facts about the heart, guys. We said it's a circulatory system. It's 2 systems in one. It's a circulatory and conduction. And did you know, and I know you already know, the heart pumps how many liters per minute? 5 liters, guys. And that's a total 1.3 gallons of fluid, of blood, right? And there's a total 7,200 liters per day, which is a total 1,900 gallons per day. And the heart has 2 entry valves and 2 exit valves. Like I show you the valves, okay? We have entry and you have exit valves. So the entry valves, the other name for entry valves is atrioventricular. We mean tricuspid, right? That's between the right atrium and the right ventricle. And the mitral, which is bicuspid, that's between the left and the right ventricle, the left atrium and the left ventricle. And then we have 2 exit valve. The other name for exit valves is semilunar. Okay, so the 2 exit valves is pulmonary valve from the right ventricle to the lungs, and the aortic valve from the left ventricle to the body. Okay, so a total, how many beats the heart beats per day, guys? 100,000. That's a lot. So around 30 million times a year. And it's like your heart is really a workforce. So just so you know, that's some fun facts about the heart. Now I'm going to put my heart right here, okay, my model. And now let's go straight into our lecture for today. We said the left versus right. At the hospital, those of you who work at the hospital, you probably heard the nurses are talking about systolic heart failure versus diastolic heart failure. It's really the left-sided versus the right-sided. So when they're talking about systolic heart failure, they're talking about what? The left-sided heart failure, okay? And when they're talking about diastolic heart failure, it's the right-sided heart failure. Now, what's going on? It's really, let me make it plain. You all know, and I know you guys learned this in school. We already know what's going on when the left-sided is not working. Okay, what is it? Or systolic heart failure. That means the heart is not contracting. That's systolic. The heart is not contracting. And with diastolic or the right-sided heart failure, the heart cannot relax, guys. That's it. So now let's break it down because we have to go through reason, the pathophysiology, the risk factors, and some medications for that. Okay, so I'm going to share my screen with you, and hopefully this time all goes well. And I thank so much for your patience. You guys know we have some struggle. Let's go to the window, and I'm going to share this with you. And I thank you so much for your patience. And I hope you can share. You can see, I can share it, and you can see. Let me know, please. Let me know if you guys can see. Maybe if you could go to the live to see if they see what I'm seeing while I'm sharing, because I see the button says stop sharing. That means they are seeing it. Okay, perfect. It's been shared. Lovely. Okay, guys. So now this is the left-sided heart failure. So this is the most common cause of the right-sided failure. So when the left side fails, blood backs up where, guys? Everybody knows the blood backs up into the lungs, right? And that causes an increased pressure into the pulmonary arteries, and that makes the right ventricle work harder, eventually causing it to fail, okay? So you know the right ventricle pumps the deoxygenated blood into the lungs via the pulmonary artery, and when the right side fails, it can't pump the blood forward into the lungs. So the blood backs up into the circulatory system. So that's usually for the right, okay? So now let's break it down again. The left-sided heart failure. What are some causes of the left-sided heart failure? Some causes may be hypertension, MI, which is myocardial infarction, then aortic or mitral valve disease, okay? So now we said the left ventricle is responsible for pump what? Oxygenated blood to the rest of the body through the aorta. And when it's damaged, what happened? It's overworked and it cannot pump effectively. And that's what causes the left-sided heart failure. So we said the heart cannot contract, guys. Left-sided heart cannot contract effectively. So some causes, we said hypertension. So those people who have hypertension, they're at risk of left-sided heart failure. Those who have MI, which is myocardial infarction, which we will discuss later, not today on the live, because that's a whole topic all by itself. STEMI versus non-STEMI, right? Myocardial infarction. This is another cause of left-sided heart failure. Then aortic and mitral valve disease. So that's what created, these are the causes of left-sided heart failure. So now, let's see. For hypertension, so people who have chronic high blood pressure, and that actually increases the afterload. And those of you who know, I don't know if you guys remember what's going on with preload and afterload. Preload, it's when the ventricles are being filled. Of course, you know, the blood goes where? Through the atrium, then it passes the valves, then it goes to the ventricles. So that's preload. And afterload, that's the pressure that needs to push the blood forward, and it goes throughout the whole body. That's afterload. So now here, one of the causes of left-sided, it's people who have chronic hypertension, and that usually increases the afterload, right? That increases the afterload. So now we have resistance to the left ventricles, and that's must overcome to eject the blood. So basically over time that weakens the heart muscles. You understand? So chronic high blood pressure increases the afterload, and resistance to the left ventricle must overcome to eject the blood. And over time, that actually weakens. What happened to the MI? How does MI contribute, or one of the causes of heart failure, left-sided heart failure? Well, with MI, guys, you already know there's a blockage where? In the coronary arteries, right? So blood supplies now diminish, right? So the artery supplying to the left ventricle causes part of the heart muscles to die, and it weakens the heart to pump effectively. So because of the blockage, now that creates the heart left-sided failure. What about aortic valve disease? So aortic stenosis, that means the aorta is closed, right? And there is a regurgitation that increased the workload of the left ventricle. And there's also a problem in the mitral valve. So the mitral valve regurgitate, that cause blood to leak backward into the left atrium, and that reduced forward flow, and that increases the pressure. So these are the three causes of your left-sided heart failure. So you understand, we said the heart cannot contract, and these are the contributing, these diseases contribute to the left-sided heart failure. Okay, so now what are some signs, symptoms? So we said in school, everybody knows, well, the blood's backing up to the lungs. So now the patient will complain of what? Dyspnea, congestions, shortness of breath, and because the blood is backing up into the lungs. Orthopnea. So if they were to sit, they would still be exhausted unless they actually have to make sure they breathe slowly, and also make sure they sit up, right? And if we were to auscultate those lung sounds, right? Listen to those lung sounds, we would find what? Crackles. And one of the key things in NCLEX, we usually see with left-sided heart failure, these people, when they spit up, sometimes we will see blood or some pink, frothy sputum in their sputum, okay? Just so you know, don't forget that. Dyspnea, orthopnea, crackles, and pink, frothy sputum. Now, what about the right-sided failure? The right-sided failure, the other name for it was what, guys? We said diastolic, right? Diastolic heart failure. And what's the other name for it? What happened? The heart cannot relax. Okay, we said with left-sided, the heart cannot contract effectively. And with diastolic, the heart cannot relax effectively. Okay, so now what happened? What are the causes? The causes of right-sided heart failure, we said the left-sided heart failure. That's one. So because of the left-sided problem, now the right actually tag along. All right. And we already know the strongest part of the heart is what, guys? Not the right sided, but it's really the left side of the heart, right? The left side of the heart is the strongest, right? Okay. And what are some causes of right sided heart failure, guys? Pulmonary hypertension. And those who have COPD, right? That's chronic obstructive pulmonary disease. These are the causes of right-sided heart failure. And why? The question is why? The right ventricle, guys, you already know, pumps deoxygenated blood into the lungs via the pulmonary artery, right? And when the heart side fails, it cannot pump blood forward into the lungs. So blood backs up into where? The systemic circulation. And that makes sense. So now, what happened? We said because of the left-sided heart failure, we said that's the most common cause of the right-sided heart failure. And when the left side fails, it backs up blood into the lungs, and that increases pressure into the pulmonary artery. That makes the right ventricle works harder. Eventually, it fails, right? The heart fails. Now, another cause of right-sided is pulmonary hypertension, the high blood pressure that's causing the arteries directly, and that actually increases the afterload on the right ventricle, straining, and it weakens it, okay? And then the third cause of the right-sided heart failure, we said, is what? The core pulmonale, or the COPD, people with congestive, chronic obstructive pulmonary disease, like chronic bronchitis, like emphysema, okay? So that leads to hypoxia, where the oxygen diminish. So pulmonary vasoconstriction, right? That caused that. And essentially what happened, it increases resistance to the lungs, and that caused right-sided failure over time. So that's a lot of pathophysiology, but I gave you already the short version, and that is a long version. So blood backs up into the body. So where are you gonna see signs, symptoms? So starting up here, you're gonna see the patient has what? The jugular vein will be distended. You already know that, okay? And that cause also peripheral edema. Their upper extremity, right, will be edematous, right, or swelling up. What about their up here in the GI? They're gonna have hepatomegaly, splenomegaly. Their spleen will be enlarged. Their Their liver will be enlarged, and they also have retention of fluid around their abdomen. And then their lower extremity will also be edematous, swelling on the upper and lower extremities. Okay, guys? So that's your right versus left-sided heart failure, or systolic versus diastolic. Okay? So again, risk factors for these heart problems, we said what? Hypertension, coronary artery disease, diabetes, obesity, smoking, and also if they had previous MI, myocardial infarction, that would cause that. So medical treatment, usually what? They would need what, guys? You know, because of the congestion, the fluid, the crackles in the lungs, they would need what? Diuretics. They will also need what? Hypertension, antihypertensive meds like ACE inhibitors, beta blockers, digoxin, okay, and oxygen therapy. And definitely, guys, they need what? What type of diet? Cardiac diet, which includes what? Low sodium diet. So any canned foods they need to stay away from unless they rinse those off, right? Or what else? Anything salty, fried foods because of the cardiac diet, because any oils that you fry, it doesn't matter whether it's olive oil, it automatically turns into cholesterol agent. and fluid restrictions is big. So that means those people, as nurses, your intervention would be what? To monitor their weight daily, okay? And educate them about their medication management and also their weight loss. That would help a lot, okay? Matter of fact, recently I found out, especially here in Miami, South Florida, there's a lot of Haitian that have heart failure. And according to statistics, believe it or not, yo di se Haitien ki gen plus problem pas même hypertension, non, heart failure. Yo di Espanol, Hispanics are the next one, but Haitian population, we have the highest heart failure in our community, the highest rate. And so much so, I said, and I'm doing my PhD, I said, maybe I should change my dissertation topic, because my first topic was to find out why our Haitian descent, our Haitian population, why we're not passing NCLEX effectively the first time. Why is this a struggle? And it's not just a language barrier, it's other reasons. So I was going to delve into, do a deeper dive into that and finding out why. I think I'm going to request to see if I could still do 2. But now recently I found out the heart failure in our community, comparing to other race, it is like one of the highest. I was like, no, I need to shift my focus. I need to find out why heart failure is so high into our race. Is it our food? Is it our lack of education? Is it like don't care attitude? No doctor. We don't want to take advice. It's whatever tastes in the mouth is not always good for us. What is it? So I wanted to find out more. And I think that's what probably I'm going to find out. Or maybe I will ask to see if I could have 2 topics, just so you know. So we said nursing interventions now, daily weights, monitor the lung sounds, monitor the edema. So definitely, especially when you're checking the pulses, you have to check everything bilaterally, the brachial, but when you come to the carotid, you got to check it one at a time. So your pedal pulse bilaterally. If you feel like the pulse is weaker on one and another, of course, we got to check it with the Doppler. And before we call the doctor, maybe patient has clots, right? But we're checking for edema, okay? So edema, how do we check for edema? Press on the end for indentation, right? It could be a +1, +2, +3, even a +4. And teach patient about weight loss, sodium management, fluid restrictions, diet, and ACE inhibitors, all those medication, triple ABC. Next week or next time we meet, we will talk about the medications, okay? Remember, we got more coming your way. MI, medications, heart valves disease. So there's so many cardiac problems involved. So just so you know. Now, these are some questions we want to also be concerned. Like when NCLEX asks you guys questions, usually they want to know which symptoms indicates worsening left-sided heart failure. You need to be able to know those things. What about why is fluid restrictions important in heart failure, right? Because especially sodium, right, draws water because these fluids, they build up on their lungs. They cannot breathe. So just so you know, we need to know the reasons. Next question. What is the priority teaching for a patient starting furosemide? You already know furosemide, it is a loop diuretic, right? When we're teaching about furosemide, guys, what are some concerns? We know it's a loop diuretic, so sodium, these are, what do you call it? It's a non-sparing potassium. So that means what? While they are diuresing, they're going to pee, they urinate, but they're also losing what? They're also not just fluid, they're not just losing fluid, but they're also losing what? Potassium. So their foods has to be replaced with potassium, like bananas, potatoes, dark leafy green vegetables and things like that. So that's the question usually NCLEX wants you to know about furosemide. What would the nurse, next question, number 4, what would the nurse, what would be the nurse's first action if weight gain is noted, especially 2 pounds a day or 3 pounds a day? That's ridiculous. That's not normal. Okay. And why do patients with heart failure needs to avoid NSAIDs? That's very important. So we need to know, right? They already at risk for bleeding. NSAIDs or what? NSAIDs cause bleeding, right? It's for clots and things like that. And next one, what electrolyte imbalance is common with loop diuretics, right? Talking about potassium, right? Why must you monitor creatinine in a patient on ACE inhibitor? So when we're doing medications, I will teach you everything about these things. We call it triple ABC, your alpha, something is happening here, guys. I don't know. And I hope you don't see that. I really need to get that word. Now they're just trying to, you see what happened? When we return to work, I don't know. During that, yes, there you go. I need to get the word. That's what it is. Okay, the next one. Sorry about that, guys. Next question, number 8. Which assessment would indicate effectiveness of treatment? Okay, of course, you have to assess your patient and see how is the treatment is working for them. Next one. Why should patients with heart failure elevate their legs? Well, we understand we want the blood to be pulled what? Backward, up, all right? And that will decrease the swelling. And they also have to wear the TED hose. We have to make sure we get the right, we have to measure their leg size, okay? The calves, which is the biggest part of the calves, the leg. So that we'll know exactly what TED hose to supply. And then remember with TED hose is 12 hours on, 12 hours off. So if we place it for them 9 a.m. before they go to bed, 9 p.m., you have to remove them. Very important. And the last question here, what is the significance of S3 heart sounds in heart failure? We understand S1, S2 is normal because S1 is lub. S2 is dub, lub dub, lub dub. But with S3, that's like an extra beat. That's a murmur, and that is not normal. Okay? So now let's go with our NCLEX question, guys. I don't know how many people we have on live, but if you're here, maybe you see my screen, you can answer. If not, you can go later and review the live, and then you can answer the question. So the first question here. A client with left-sided heart failure reports waking up, gasping for air. What is the priority nursing action? Okay, the client has left-sided heart failure, reports waking up, gasping for air. What is the priority nursing action? We already know it is normal for them to have what? Shortness of breath. But because that's part of the disease process. But what do we do? What is your nursing priority action? That means what should you do about that? Okay, because they can't breathe. So number 1, do you assess breath sounds? Number 2, do you obtain daily weight? Number 3, do you administer PRN morphine? The next one, the D, do you elevate legs on pillow? You guys have the answer already? I cannot see the chat. I don't know who answers. All right, here we go. You don't have the answer? The answer is A. Assess breath sounds, guys. And it's really talking about the shortness of breath. And A is what? A says assess breath sounds. Yeah, because they're not breathing properly. So rationale is paroxysmal nocturnal dyspnea indicates pulmonary congestion. Assessing breath sounds help determine the severity and guides intervention. So we understand with nocturnal dyspnea, it's caused pulmonary congestion due to fluid backing up into the lungs. So your first priority is to assess breath sounds to determine the severity, such as crackles. What else you're trying to determine? Indicating, yeah, crackles, that's what indicating fluid overload. which will guide further intervention like oxygen therapy and diuretics. Of course, before we start oxygen, guys, we elevate the head of the bed, right? And we check the pulse ox. Then we start oxygen and get, especially we could start with 2 liters and then get a order from the doctor later. Okay. All right. So why not B? And B was to obtain daily weight. That's important, fluid retention, but that's not a priority. C was to administer PRN. That's for pain, not the first line of intervention. And D, elevate legs on pillow. That actually can worsen pulmonary congestion by increasing venous return. You don't want to do that, okay? Because you don't elevate the legs for that, okay? Now, number two, guys, which indicates effective IV furosemide therapy in right-sided heart failure. Which findings indicates effective IV furosemide therapy in right-sided heart failure? I hope you guys can see my screen, and you already know furosemide, which is Lasix. It's a loop diuretics. It's non-sparing potassium, so that means I'm losing fluid, and I'm also losing potassium. So they're asking you here, which finding indicates that Lasix is really working? A, BP 88/50 millimерcury. B, weight loss 1.5 kilogram in 24 hours. C, potassium 2.9 milli equivalent per liters. And D, urine output 30 ml in 8 hours. What is the answer, guys? How do I know Lasix is working? The answer is B, weight loss 1.5 kilogram in 24 hours, because remember, fluid overload, that caused them to have weight gain. All right. So 1.5 kilo in 24 hours, that's not bad. Okay. So we said the rationale is rapid weight loss suggests diuresis and fluid volume reduction. So that means it's working. So it says here, weight loss reflects fluid removal, a key goal in heart failure management. Losing 1.5 kilograms, that is a total 3.3 pounds, suggests effective diuresis. Okay, so that's a good thing. So why B was not the answer? Blood pressure 88/50, that's hypertension. You don't want the pressure to go that low. Okay, so that is a signal of too much fluid or being diuresed. Okay, so that means the doctor would need to adjust the medication, but that doesn't mean that Lasix is working effectively. And potassium, which was C, potassium 2.9. What is the normal potassium, guys? 3.5 to 5. And in NCLEX, we don't call the doctor unless potassium is 6.0. Okay, so that is not normal. So that indicates hypokalemia. So I know this cannot show that the potassium is working. By matter of fact, Lasix lowers the potassium, okay? And that is a complication of a loop diuretic, but it doesn't mean that it's working effectively. You understand? And D, urine output is 30 ml in 8 hours. That is too little, because they should void at least 30 ml per hour, not in 8 hours. So that shows inadequate tissue perfusion, dehydration. Number 3, guys, we got 7 more questions after this and we're done, okay? Number 3, the provider prescribed spironolactone. Which lab value requires, guys? You already know where spironolactone, it is a sparing potassium, especially those who have kidney problem. Okay, so we have to make sure they test. They're seen by the nephrologist before they place on this drug. So which lab requires follow-up? Sodium 136 per milliequivalent per liter. Potassium 5.4. C, BNP 480 pg per ml. You already know BNP, when your patient has heart failure, guys, it is a must test that needs to be done, because that indicates the percentage of heart failing, right? So we already know BNP, the normal BNP must be below 100, 100 below. So when it's like going up, 200, 300, 6, 4, 5, that is like, that indicates the heart is really, really failing. So BNP, not BMP, not basic metabolic panel, which is for electrolytes, right? For your potassium, your chloride, sodium. But the BNP, that's the brain natriuretic peptide. That needs to be done, especially if your patient has heart failure, to see the percentage, okay, of their hearts failing. Okay, so D, creatinine 1.0. So the answer is B, potassium. Yes, that's the answer. Those of you have potassium, kudos to you. Potassium greater than 5.0 indicates risk for hyperkalemia, a concern with potassium sparing diuretics. Okay, that's why if they have kidney problem, this would not be a best drug for them, guys. Very important. Okay, by the way, I don't know if I told you about the EF, that's ejection fraction. The normal EF must be what? 55 to 65. Some textbook says 55 to 70. That's really indicates what, guys? Ejection fraction, the force that needs for the blood to be projected throughout the whole body, okay? The pressure. And when people have low EF, that means what? The heart is failing. The heart cannot contract. Whether if it's systolic, the heart cannot contract effectively. If it's diastolic, the heart cannot relax effectively. That's what? Left versus right-sided again. Okay, so we already know spironolactone is potassium sparing. That's why we have to check their potassium. Next question, guys. Oh, man. You already see the answer, but that's okay. Okay. Which patient statement reflects appropriate understanding of low sodium diet? Which patient statement reflects appropriate understanding of a low sodium diet? A, I can use soy sauce if it's light. B, canned veggies are okay if friends. C, cheddar cheese is a good snack. And D, I'll season food with salt substitute. What's the answer? You already see the answer. B is the answer. Yes. Canned foods, canned veggies are okay if rinsed. So what is the rationale? It says rinsing canned vegetables can help remove excess sodium. Other options include high sodium contents like you guys saw, and that will increase their level of potassium. That's not good. All right, number five. Okay. A new S3 heart sounds is noted in a patient with heart failure. What does this indicate? A, normal findings in older adults. B, signs of fluid volume overload. C, suggests mitral valve prolapse. D, indicates pericardial friction. S3 heart sounds is noted in patient with heart failure. What does that indicate, guys? We already know it's not normal. The answer is B, signs of fluid overload. All right. And A, in older adults, that's false because S4 may be normal in elderly. S3 is usually pathologic. Okay, did you guys know that? And C, why C is not the answer? Suggests mitral valve prolapse. No. It says MVP may cause a click, not S3. And then D, why D is not the answer? Okay, indicates pericardial friction. Is that what it is? No, it says here it produces a friction rub, not S3. Okay, so these are the rationales. Okay, next question. Which medication combination should be questioned by the nurse? A, lisinopril and furosemide. Remember, this topic is left and right-sided heart failure or systolic versus diastolic heart failure. Which medication combination should be questioned by the nurse? A, lisinopril and furosemide. B, carvedilol and digoxin. C, losartan and spironolactone. And D, hydralazine and isosabide denitrate. What's the answer? Which medication? The patient has heart failure. Which medication you need to question? That means that's a medication that patient cannot have. The answer is C, guys, which is losartan and spironolactone. It says both losartan and spironolactone can increase potassium sparing, which is lead to what? Hyperkalemia. Okay? Just so you know, losartan and spironolactone increase risk for hyperkalemia. And that's why usually you don't see losartan and spironolactone on the list. You'll see ACE inhibitors, you see beta blockers. Okay? All right. So why carvedilol? Why not B? Which says carvedilol and dig both affect heart rate, but often used together in heart failure with careful monitoring. And why not hydralazine and isosabide? It says they are safe combo, especially in African American male patient or female patient. Question 7, guys. We're almost done. Why are NSAIDs contraindicated in heart failure? Remember earlier I did say patient with heart failure, they cannot have NSAIDs, right? Not. A, it decreases the afterload. B, it causes sodium and water retention. C, it potentiates diuretic effects. And D, it increases their MI contractility. Anybody can take a guess? I don't know if people are putting their answers. I know cardiac is usually one of the hardest topic people are struggling with. That's why the next few weeks, I'm going to focus on cardiac. Why NSAIDs are contraindicated in heart failure, guys? The answer is B. Well, if you got B, that's the answer. NSAIDs reduce renal perfusion and cause fluid retention, which worsen heart failure. We don't want that because they already have, especially the left-sided, it's actually accumulated in the lungs because the blood is backing up in the lungs. And then the right-sided, it's backing up in the body. So they have fluid overload everywhere, whether with right or left. So you don't want to consume NSAIDs. You don't want to teach them to consume NSAIDs. Make sure you teach them not to consume NSAIDs because that will actually increase more fluid overload and worsen heart failure. All right. So A, decrease afterload, not true, not for NSAIDs. C, potentiate diuretic effects, opposite, they blunt diuretic response. And D, why D was not the answer, which increased myocardial contractility. That's incorrect. They have no positive inotropic effect. Number 8, a patient with BNP increased from 800 to 1200 pg per milliliters. What is the nurse best action? We already know, I told you the BNP, that's one of the testing must be done to find out how much failure the patient has. All right. And we said the normal was what? You guys remember? Has to be less than 100. 800, they're like way up there, guys. Okay. So patient with BNP increases from 800 to 1200 pg per ml. What is the nurse best action? That's something you're going to do. You're not going to assess, but you're going to intervene for that patient. A, restrict fluid to 500 ml per day. B, notify the healthcare provider. C, administer IV morphine. And D, apply nasal oxygen at 4 liters per ml. The BNP, the heart is failing. 800 is a very high number. I can tell you that much. What will you do? Would you restrict them, their fluids intake? Would you notify the healthcare provider? Would you administer morphine? That's for pain. And would you apply nasal cannula oxygen? The answer is B, because you cannot restrict them from their fluids. That's not your right. You cannot administer morphine. They're not in pain. That's silly, right? And then apply nasal. This is not a respiratory problem. So the answer is so obvious. So when you notify the doctor, definitely the doctor, what do you think he's going to do? He's going to do more testing. He's going to find out what's going on with the patient and see how he can help the patient. You guys understand? So definitely they're going to be doing more testing. So it's actually going to help the patient. Okay. So it requires the provider to revise their medications and their care. So we're not going to do any of that. Number 9, a patient on digoxin has a heart rate of 52 beats per minute on a serum and a serum level of 0.9 ng per ml. Okay, digoxin. Remember DIG. We have DIG, that's toxicity. We have to check the therapeutic level. We have to know the toxicity level. So when we do meds, we'll tell you more about DIG. So what is a nurse should do? Number 1, administer the dose as scheduled. Everybody knows that answer, right? Hold the dose of the drug. C, administer atropine. D, draw potassium level. The answer, I know you have the answer. Yes, because it's below 60, because we know DIG going to lower the heart rate, but it's going to strengthen the heart. Okay, we have to hold it and let the doctor know. Okay. And number 10, our last question. What is an appropriate discharge goal for a patient with a chronic heart failure? Patient is getting ready to be discharged. What is your priority goal, discharge goal for that patient? She has a chronic heart failure, whether it's right or left. A, maintain oxygen saturation above 88% on room air. B, gain less than 2 pounds per week. 3, or C, walk 3 blocks without dyspnea. And D, limit fluid intake 3 liters per day. You guys have the answer for that one? This is the last question. Your discharge goal for your patient before they go home. What do you want to teach them? About their oxygen intake? What if they gain less than 2 pounds per week? Walk 3 blocks without dyspnea? Or limit fluid intake to 3 liters per day? What's the rationale? The answer is C, guys. Being able to tolerate moderate activity without symptoms shows improvement in functional status. That's the answer. Okay. That's the answer. Any question, guys, for me? Hello? Any questions regarding left-sided versus right-sided? So we said left again was what? The other name for left-sided is systolic. And what is the problem with systolic heart failure? The heart cannot contract. And with the right-sided, the other name for it is diastolic. The heart cannot relax effectively. So just so you know, how many pounds, back to our last question, how many pounds your patient gained before you call the doctor? Okay, we said earlier with the Lasix, if they lose 1.5 kilogram pounds per day, which is 3.3 pounds per day. That shows the Lasix is working effectively. But how many pounds can they gain before you can call the doctor, right? Because they got to be weighed daily. More than 2 pounds in one day, guys. Is that okay? No, no, no. Or 5 pounds per week. If your patient gain 5 pounds per week or more, or 2 pounds a day, you have to call the doctor. And that can be an NCLEX question. No more than 2 pounds a day and no more than 5 pounds per week, guys. All right? So they cannot. Once they gain 2 pounds or more per day, we got to call the doctor. Or 5 more pounds per week, we got to call the doctor. And that's all, guys. That's all for left-sided versus right-sided heart failure. And I don't know if I have any questions. And I thank you guys for joining the live. I was not able to see comments, anything like that. But I thank you for joining. And until next time, you guys can share the live and I will let you know. If not next week, I'm not sure if we're coming back on Sunday, but maybe on that Thursday of the same week, because we want to continue to show more topics on cardiac and answers. Don't forget, guys, I have 2 books on NCLEX prep, just so you know. The books, let me see, let me grab them and show you guys right here. The first one, guys, it's all about the blueprint on NCLEX, the blueprint of NCLEX. Like those of you who've been to NCLEX and you did not pass, and I'm sure you received the blueprints and tell you the rationales why you did not pass. So that's the blueprint, whether it's physiologic, integrity, whether it's psychosocial, whether it's managed care, whether it's basic care comfort, and they tell you your percentage, whether you have moderate passing or near passing or above passing. So all the blueprints, guys, it's here for you with answers, with I break it down just so you can understand it. And we also have questions, and about 400, close to 500 questions in this book, and most missed questions on NCLEX. And we also have some critical care techniques. What is it? Strategies and techniques to pass your exams. It's also included in this. And last and not least, we have medical terminology. So this book, and I have the other one, which is case studies, which is all 10 types of NGN. We're talking about drag and drop, bow tie, the matrix, the select all that apply, the, fill in the blanks, you name it. All the 10 types are in the book. It's actually less condensed, less dense, but just so you know, it's a package, and I'm receiving a donation. I call it donation because when I do my research, these books should have been more. And the price that I really put on these 2 books, it's like a donation. So just so you know, it's call me and I will give you the price. And I'm also open to have a class, a live class with whoever, or if you're out of states, let me know. I could do online class. So far I have 5 people, but usually I like to start with 10 people. So if you are interested in joining my class, my online class or my live class, please let me know, okay? So I can help you. Again, my name is Mrs. Leon. I am an MSN nurse. I've been a nurse since 1998. And presently I teach in 3 colleges. I am also a doctorate student at Barry University. And just so you know, I have been doing my NCLEX review since before COVID, and I really enjoy teaching. All right, so just so you know, call me. My number is 201-889-8103. Again, the topic for the day, I'm gonna see if I could put it on the box here because I lost my live and everything was erased, but I'm going to put the topic again. So let me see if you have any questions right here. Let me put the private chat here. My name, Mrs. Leon. Any questions, guys? You can ask me any questions. Go ahead. No questions regarding the topic of today or any other topics or any other concerns? Or are you guys scheduled to go take your exams? You have scheduled dates, you probably do. And how often, how much you study? Some people, they got to quit their job. How much time you put in? How much effort you put it into it? Okay. It's very important. I want to put the title of our today's here before. I don't know if you could, where can I add that? Let's see, where can I add that? Not on the private chat. I'm going to add, guys, because I lost, there you go, it was here, so I just have to show it. Ticker. Okay, perfect. Thank you so much. All right, guys, do I have any questions? Any questions, guys? Any questions? No? Do we have any questions now? Okay. You guys know you could put it in the chat, or maybe I don't see it. Oh, let me check my chat. Marie, welcome. Mika, welcome. Thank you for joining us. Yes. Any comment, anything? So you guys now, you understand the concept of right versus left-sided failure. I have more questions on that, just so you know. But today we are done. Maybe next time what I can do, I will be asking you more questions on cardiac, because I have more cardiac questions for you. And we could have a longer live, but you know, thank you so much. And please share the live, and we will see you next Thursday. Okay, next Thursday. Thank you so much. Put your name so I could meet you, put your number, and you can contact me, guys. Have a wonderful evening, and thank you so much, guys. All right. Since you don't have any questions for me, I'm done. God bless. Let's have a word of prayer before we finish. Father God, we thank you so much for allowing us to have a successful live, even though we had troubles in the beginning, but you have helped us to pull it through. So we ask you to please be with those who are joining this live, Lord. Our topic today was a very important one, cardiac, which is one of the hardest topic in the nursing field, or even the concept to understand, because it is a hard concept to understand. We ask you to make it plain, to make it easy to our learners today, and those of them who are getting ready to go past their NCLEX, Lord, may they be successful. May they have time to study. May they they'll be able to apply and analyze the concept and be able to regurgitate it and be able to pass next time they go, Father. And those of them who are still in school, Father, give them intelligence from above and help them to be able to graduate safely in Jesus' name, Father. Amen. Amen. Thank you so much, guys. Bye.